वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। Om.
Thank you. Now, with the blessings of Almighty, let us start the event. We are privileged to present in this occasion. We'd like to present about hetero healthcare through a small video.
At Hetero Healthcare, we are committed to improving lives. For over 30 years, our journey has been driven by one purpose: to enhance the quality of life through continuous innovation and advanced healthcare solutions. Presence in 126 plus countries with 36 state-of-the-art manufacturing facilities. Backed by a century's worth of experience, our team relentlessly pursues excellence. We aim to improve the people's quality of life with a wide product range encompassing multiple specialties and continuous research and development process with 1,000 plus top-notch scientists. We are more devoted to finding tomorrow's cure and the treatments for some of the most critical diseases. Over 2 decades of experience in developing APIs, among the largest manufacturers of ARV, APIs, and FDFCs in the world, is a testament to our commitment to high-quality active pharmaceutical ingredients, pushing the boundaries of healthcare solutions. 21,000 employees working globally. In just few years, we introduced 4 groundbreaking 300 plus products, 314 formulation, distinction of bringing 4 biosimilar products to market within 5 years of initiation: Darbepoetin Alpha, Rituximab, Bevacizumab, Adalimumab, and 360-degree solution provider, revolutionizing treatment for millions. Our product range spans multiple specialties, from antiviral medicines to pioneering innovations like Fluvir. During COVID-19 pandemic, Covi4 Remdesivir is our contribution to serve country and humanity, instrumental in the fight against COVID-19. Our achievements are recognized globally. Won Express Pharma Excellence Award for COVID-19 drug launch, rewarding our contribution to provide Covi4 Remdesivir access to more than 1 lakh patients. Largest manufacturer of HIV drugs, largest manufacturer of antiretroviral drugs, manufacturer of wide range of anti-cancer drugs. Our commitment to innovation goes beyond healthcare. In June 2023, our sister company Azista BST Aerospace proudly launched its first microsatellite, marking a new milestone. As doctors care for their patients, We Care for You initiative fosters a unique bond of trust, offering support not just through products. We Care for You is not just an initiative, but an emotion committed to you and your paramedical staff. Hetero Healthcare is committed to a healthier world for everyone.
Thank you. Thank you for allowing us to showcase our organization, Hetero Healthcare. Now, I'd like to share with you this program, Compass. Today's module, we are live webcasting to 9 other locations apart from Mumbai. Mumbai, we are webcasting this particular location, that is Mumbai Western. Apart from that, we have Mumbai Thane also, we have another program going on. Same, we are live casting. Rather than that, we have Kolkata, we have Pune, we have Hyderabad, Thane, then we have Bangalore, Nagpur, and Surat. I welcome all the delegates sitting over there. Thank you for coming, and shortly we'll start the event. Now I'll like to request Dr. Khandeparkar sir to come and introduce our esteemed speaker.
Thank you, Sumantini. Welcome to all the doctors once again to this scientific program on allergic rhinitis and rhinoconjunctivitis, the module that we'll discuss today. This scientific initiative is facilitated by renowned immunopathologist and allergologist, Dr. Sitesh Roy. Welcome, sir. Dr. Sitesh Roy is MBBS, MCPS, MD, FAAP, FAC, AAI, FAAI. Sir is USB board certified super specialist in immunology, allergy and asthma. Founder director of Dr. Roy Health Solutions Multi-Specialty Clinic, Bandra, Mumbai. Ex-associate professors of pediatrics and medicine at University of Mississippi Medical Center. Ex-associate editor of Annals of Allergy, Asthma, Immunology. Dr. Roy has authored a number of articles and publications for leading medical journals, as well as a book chapter titled Stress and Allergic Diseases. In addition, Dr. Roy has given many lectures and presentations on asthma, allergic sinusitis, indoor and outdoor air pollution, food allergies and hypersensitivity, drug allergy, etc., both nationally and internationally. With this brief introduction, I welcome Dr. Roy. Sir, over to you.
A very good morning to all. Welcome on this Sunday morning. Again, we are meeting after a long gap, but a lot of good stuff has been going on in between, and I'll fill you on that in a little bit. But the topic for today is allergic rhinitis and rhinosinusitis, a very common problem, probably makes up to 40% of visits to a general practitioner's office. And to any of our specialty office, it could be even more. What I'm going to go through is a little bit of brief overview. As you have seen in the previous image that was kept, we've been through 4 modules already. This is the 5th module. The first 2 modules were looking at the etiopathogenesis of allergies and the reason why allergies are rising. It was a very interesting discussion, went on for an hour beyond time. We then had allergic and non-allergic diseases and had discussed at length atopic dermatitis. And today we're going to focus on allergic rhinosinusitis. And from here on, most of the modules will be independently done. We combined the first few together, but here on it will be one module at a time. And in today's module, we discuss the upper airways. In the next module, we discuss the lower airways and the allergic impact on all of those parts of our body. So can we have go back to the slides, please? So we know that allergy is a very big problem. It's rising all over the world. Estimates say that there may be up to 30% of people in the world who have some form of allergy. When I say some form of allergy, it may be an allergy to a cosmetic, an allergy to a drug, an allergy to a food, an allergy to in their nose or lungs, an allergy in their gut, a food intolerance. There's a very long list of things that is included under allergies, as you saw in the 12 modules. And a large proportion of these patients are starting very early in life. So there was a time when I remember I was doing my pediatric residency in America, and we would be told that kids below 3 years of age are not allergy tested. Okay. We were told that don't think about allergies in children below 1 year of age. And clearly, when I had left India, it was very clear that the allergic diseases, this was 1997, weren't as high. But after I came back in 2011, it is very clear to me that allergies are starting very, very early in life. The kind of patients I would see having, having atopic dermatitis in the first week of life, or having allergic rhinitis at 6 months of age, which was something that I don't remember ever seeing in my medical training in India, even on the pediatric wards, which I did sincerely, is something that I see very routinely in my practice now. Having said that, we had gone through the modules where diet, lifestyle, environmental factors, we had looked at it in detail, how they're increasing. And a very big factor is stress. And we will talk about that a little bit more towards the end of the presentation also. Now, why are we talking about rhinitis? Because when you look at the worldwide prevalence of rhinitis, allergic rhinitis makes up about 18%. And non-allergic rhinitis makes up about 12%. This used to be a 50-50 split in number of patients before, but now allergic rhinitis is more like 60-40 in favor of allergic rhinitis, suggesting that we are having a lot more atopic diathesis, if I may call it, which is triggering these rhinitis bouts and symptoms in patients. When we look at the Indian population, some form of allergic disease estimated 20 to 30%. Take into consideration even if someone gets a rash by using something on their hands, which is an allergic contact dermatitis, everything included, about 1/3 of people have some reaction or the other. And when you look at the breakdown when it comes to burden, we are talking about almost 30 crore patients. And this is the mediating antibody that we're going to be talking about today, because you're talking largely allergic. I'll touch upon non-allergic, but that's not the focus of today's topic. But remember, this molecule has a very important purpose in our body, and that's to fight parasitic infections. Definitely has some role in certain viral infections too, which we know. But when it goes haywire, it can cause allergies and hypersensitivities. And when it goes really bad, it can cause anaphylaxis. So as we know, allergic rhinitis is an inflammatory condition of the nasal passage, which causes itching, nasal discharge, sneezing, and obstruction. The induction is by exposure of IgE-mediated immune response, which affects the nasal mucosa and causes hyperreactivity. Prevalence is rising when we look at even children in a study called ISAC study, International Study for Asthma and Allergies in Children, a very wide study done through almost 100 countries around the world. India had about 30 centers in the second part of the ISAC study. There was ISAC 1, then ISAC 2 and 3. And in this, it was found that when school-age children between the ages of 6 and 7 were screened through very good questionnaires, it was found that prevalence of allergic rhinitis was almost 8.5% in that age group, and it was almost 14.6% as the kids got into the teenage years. And interestingly, allergic rhinitis peaks between 20 and 40. So a lot of my patients who see me in my practice, I see all age groups, pediatric and adult, are actually young adults who have had onset, or they are middle-aged adults who've had onset of these problems. And again, the estimation is there are numbers that go up to 40%, but it's estimated about 20% of the Indian population has manifest clear or is at risk for allergic rhinitis. So that itself is a very high number of 25 plus crore patients. Looking at the pathophysiology, this has evolved over time. This used to be a very simple picture before, and even now this is not a very complicated picture according to me. What we find is that the allergens, when they enter the nasal epithelial cells, not in everyone, you have to remember we are calling it allergens, they're actually proteins. They're proteins that have been around us since thousands of years. Our body is supposed to see them and ignore them, which is immune tolerance. But when it is primed, as I may call it, to have a fighting response, is when this substance, same substance that comes in, goes to the antigen presenting cell, which should then present it to the T lymphocytes and subsequently the B lymphocytes and make IgG, which is our immune tolerant pathway. But in this system where your Th2 deviant, these cells go and make B cells, which make IgE. These IgE from the mast cells and basophils get coated. When they are coated and the allergen comes in and it cross-links these IgE molecules, you get release of mediators. Now, in any allergic phenomenon, there are two phases. There's an early phase and a late phase. In the early phase, you get histamine, tryptase, chymase, kininogase, heparin, prostaglandin. There's a long list, all the leukotrienes. And what you get is mucosal edema. You get sensory nerve stimulation. And this is very important because these afferent nerves go all the way to the central pathways and cause an efferent response, which enhances and multiplies the response. So one sneeze will lead to multiple sneezes, one scratch will lead to multiple scratches, and this becomes a self-perpetuating cycle. So you get the acute symptoms, and then you have the late phase response, which happens after 4 to 6 hours. Now imagine if a patient has perennial allergic rhinitis like house dust mite allergy, they are now in a constant cycle where everything merges, acute, chronic, but there's always acute worsening that we see, and the chronic part becomes their daily routine, which may include partial blockage of the nose, it might include random sneezes, it might include a runny nose here and there, which they may then attribute to cold air. They may attribute to strong smells, which is the irritant component acting on top of the inflammation that the allergic component has already caused in the lining. And in this late phase, as you can see, there can be a different kind of cytokine profile with the IL-4, IL-13, which is what perpetuates the allergic mechanism to go on both locally and systemically in the body. And in this, there can be infiltration of T cells, eosinophils, basophils, neutrophils, monocytes, and you get the chronic symptoms. And bottom line is you end up with sneezing, itching, runny nose, blocked nose, ocular symptoms. Many of these occur in different combinations. Now, we all have seen patients, some of whom have only ocular allergies, some of whom have nasal and ocular allergies, and some who have only nasal allergies with zero ocular symptoms. There is nothing that can predict who will go which way, but that is kind of what we see in practice. This is just the same thing mentioned slightly differently. This was an older slide. What I showed you previously was a newer slide. Now, what happens with these patients? And I think that this slide is probably a very, very important slide in this presentation, because we don't always tune in to what the patients are coming with, because the trickiest part about practicing medicine is that the patient does not read the book and come. So the patient has not read all the manifestations, all the symptoms, all the signs, and they present sometimes with very, what I would call, unique combinations of problems in which you may only have one out of these things. And I've had cases like that. And you have to have a high level of suspicion to suspect allergies in such people. So I have patients who never ever sneeze and they still have allergic rhinitis. Okay. I have patients who never ever have a blocked nose and still they have allergic rhinitis. I have patients who never ever have an itch in their nose and they still have allergic rhinitis. Point I'm trying to say is that you have to have that, what I would call in today's day and age, a very sharp antenna to pick up these signals. And so the range can be from sneezing, nasal itch, congestion, sore throat, recurrent sore throat. I've had several patients. I had one patient who came to me with a history that they were having blood in their sputum. They had been worked up for 9 months for everything from tuberculosis to whatever else you can think of that will give you blood in the sputum. When I saw that patient, took a very careful history, did a very careful examination, it was one of those cases that really was so unique because the appearance of the posterior pharynx, or for that matter, 1+ size tonsils, was very unremarkable. But then the girl did something in front of me, which the parents said she used to do all the time. And she's a young girl, probably around 10, 12. She was making these weird clicking sounds from her throat. She had, again, no classic nasal allergy symptoms, okay? Nothing. And that kind of a click is the human being's way of trying to scratch their throat. We know that because we've seen it in our practices and in our training. And when I tested this girl, she had very severe allergies on allergy skin testing. We went on to give her medications and then start her on allergen immunotherapy. Today, she has not had any blood coming out in her sputum for the last 2.5 years. She's almost coming to the completion of her 3 year of immunotherapy. And in many other ways, her life changed a lot. So recurrent sore throat, you can't just assume because there's not much of rhinitis going on or ocular symptoms going on, can't be allergies. Some allergies are weird. They will affect only one part of a system, and you still have to have a suspicion of that happening. Recurrent infections, we can understand that the lining of the mucosa is completely what I would call imbalanced. And so viruses latch on much easier, bacteria latch on much easier, viruses and bacteria make permanent homes much easier. And because of all of these reasons, they can then create a long-term infection or even recurrent short-term infections in a person. Halitosis, bad breath, can sometimes be one of the only features. Respiratory distress, infant. I recently, again, this was a new, I've been in practicing allergy for 25 years now. I still see something new in my clinic. The other day, I had a gentleman in his 40s whose presenting symptom was choking and gasping for breath. Now, anyone who hears choking and gasping in a middle-aged male would start thinking of other more serious causes. But when you take a very careful history, he's having a very severe degree of nasal obstruction that literally makes him feel that he's choking and gagging. And they had videos with them to show me what it looks like, and it was quite scary. So though I say respiratory distress infant, you cannot underestimate if someone has a high level of sensitivity that even an adult could present like that. Hypernasality, nasal twang, what we call to the voice. A postnasal drip can have a wide manifestation of symptoms with just this complaint, and then a cough. I've had a fair share of patients who had allergic rhinitis, but gave very little nasal symptoms, one that you would attribute to Mumbai's air pollution. Okay, wouldn't call it allergies. And yet their cough was so bad that when we treated their allergies, their cough literally disappeared. The comorbidities of allergic disorders in allergic rhinitis, as you can expect, ocular allergies is a big one. I'm not going to go into that today. We'll cover it in a future module. Pharyngitis, as we discussed, sinusitis. Pharyngitis would be like a recurrent kind of pharyngitis. Sinusitis, asthma, we very well know. We'll see a slide on it. Eczema, otitis media, lymphoid hypertrophy. I get so many calls from pediatricians from across India, okay, saying that they have adenoid hypertrophy or tonsillar hypertrophy in these children. They're just not responding to any antibiotics, oral steroids, nasal sprays, you name it, okay? The degree to which their lymphoid hypertrophy is occurring in their upper airway is really very, very disconcerting and troublesome. Even to the point when we go into the adult age group, obstructive sleep apnea, snoring, we get kids, 3-4-year-old, snoring as loud as the grandfather or grandmother is in the house, okay? Scary. Speech impairment, I've definitely seen my share of this in my practice. Dental problems, huge issue. If allergies are not picked up when they occur early and the kid starts getting their permanent teeth, you're not talking about several lakhs worth of orthodontic treatment when the kid is 15, 16, 18, 20 years old. Okay, that's the economic impact of allergic rhinitis. People say, "Kya hai, sardi hai, hote rehta hai, dust sab jagah hai." The impact is immense. Immense is the only word, and the economic impact can be massive. Failure to thrive. I've had my share. Kids just not growing, just not developing. Their entire energy, the way I call it, of the body is going and fighting inflammation and breathing. And when you get that corrected, they put on weight, they become healthy, they are happy, they are sleeping so much better. It's really phenomenal. What does all of this lead to? Reduced quality of life. I'm spending a lot of time on this because I know that all of you all have seen cases like this at some point. But when you put it in perspective, you realize that we are probably not testing enough people for allergies when we should be testing them. We already know about the one airway, one disease hypothesis, which suggests that with, for example, house dust mite allergic rhinitis, you have the upper airway manifestation, but you can also have the lower airway manifestation. And children with allergic rhinitis have a 2 to 7-fold increase in the risk of developing asthma. So we are talking 200% to 700% higher than the population risk of developing asthma. And in patients who have asthma with significant rhinitis, both kids and adults, their chance of having difficult to control asthma becomes much higher if their allergic rhinitis is not well controlled or not diagnosed, which I do still see in today's day and age, where they're being treated for asthma, but nobody has looked at their upper airway or asked about their upper airway or treated their upper airway. And as you can see, the overlap is very, very high between these two. When we look at the classification of allergic rhinitis, the ARIA guidelines, which is the impact of allergic rhinitis on asthma, gave these kind of what I would call reference to us to kind of help us correctly classify the patients, so that if you classify them correctly, you can treat them correctly. And so intermittent symptoms, which is less than 4 days a week and less than 4 consecutive weeks in a year. Then there is persistent, where it's more than 4 days a week or more than 4 weeks in a year. And then it's mild, where it does not affect their sleep, activity, play, work. And it's moderate to severe when it starts affecting their sleep. I would say even snoring falls into that category, even though maybe sleeping, but they're still snoring, it's abnormal. Impairment of daily activities, sports, leisure, problems at school or work. I get a lot of adults who don't even realize that they're performing at 60, 70% of their full capacity till their allergies are treated. And after you treat their allergies, they enhance their efficiency, their efficacy, their productivity. Everything just skyrockets, because 30% is a lot. It's a third of what a person can do. And then just troublesome symptoms. The comorbidities I've already mentioned, I've added here with sinusitis, polyposis, which we'll briefly talk about. And learning and attention impairment goes through for kids and adults. Okay, this is not only for children. So if we were to look at the impact of rhinitis on quality of life, again, this is something that was published by the World Allergy Organization in 2015. Sleep getting affected, 61% patients. Mood getting affected, 59.9. This is very important. I have couples coming to me where either the wife is coming with the husband, wife is the patient, or the husband is coming with the wife, husband is the patient, where the spouse, after the first visit, without saying anything, me comes and profusely thanks me the second visit. And I ask them why, because they say, ये सबसे चिड़चिड़ा और सबसे बेकार पर्सन था टू लिव विथ. आपने उसके एलर्जीज ठीक कर दी, अभी वो बहुत अच्छा बिहेव करता है, बहुत शांत रहता है, लड़ता नहीं है, झगड़ता नहीं है, अच्छे मूड में रहता है. Same with parents and kids, kids and parents, behavior changes. Physical activities getting affected, almost 50% people. Work performance getting affected, personal relationships. There are studies which have shown that having allergic rhinitis impacts the sexual life of an adult significantly, like up to 45 to 50% patients with allergic rhinitis say that their sexual life is affected by allergies. And I'm saying only nasal allergies. It's not like they have respiratory problems, asthma or something else that's going on. So, and then school performance, we've already discussed that. So in this, again, I've given a little bit more expansion of the impact of allergic rhinitis. School absences, clearly have seen that. I get cases coming to me from all over India and the Middle East, Southeast, Asia, Europe, US. Some of these kids have major issues. I just had a kid who has not gone to school for about 6 months now, because every time he goes to school, he falls sick. He gets a viral infection. When he doesn't have a viral infection, he's got rhinitis or sinusitis going on. And we put him on a very good treatment plan, and he's back in school and doing very well. Distraction, frustration, fatigue, irritability, impaired learning and memory, very important for kids. Then you take the side effect of the medicines that they take. Okay, some of the antihistamines that are still used have drowsiness in them. We'll talk about that a bit more later. Isolation, not a small thing. When a person is having chronic nasal symptoms, they tend to not want to interact with a lot of people, go out, be amongst people. They have restrictions in what they can eat and drink, because they figure out that those make their rhinitis worse. Leads to so low self-esteem. And again, I've seen my share of patients with anxiety and depression just because of allergic rhinitis, allergic rhinosinusitis, allergic rhinitis with asthma, who have done so much better, means on medications for depression, who have come off medications where they've been treated well. All this leads to even more stress. Remember, stress leads to increased risk of allergies and allergic diseases. Now, the allergic disease itself increases the stress. Adverse impact on parents' quality of life. I've again had kids who had allergic rhinitis since the first year of life. Parents have not had a good night's sleep in 6, 7 years, they tell me. Every night, for some reason or the other, kid wakes up itching, scratching, sneezing, blowing, having trouble breathing, rhinitis triggering the asthma. You can only imagine what these people go through. Anxious parents, overprotective parents, work absences for the parents, and then again, limited social life for the whole family. I think sleep disorder, breathing, daytime fatigue is not something that anyone won't understand here. We've all seen it. But the second part is very interesting. They actually did studies in patients with seasonal allergic rhinitis. So these are mostly the pollen-induced allergies, nasal allergies. They found that these patients have hundreds, okay, not 10, 20, hundreds of brief, subtle awakenings, which are called micro arousals every night, okay? And they are not even aware that they wake up, but they are fatigued and tired the next day. And they have difficulty falling asleep or staying asleep because of this. So now we come to the causes of allergic rhinitis. Okay, the commonest ones, anywhere you go in the world, any part of the world, house dust mites, grass, tree, and weed pollen. Grass pollen is typically a summer allergen. Tree pollen is a spring allergen. Weed pollen is a post-monsoon. It can have other seasons also. Cockroaches, not a surprise. The insect itself does nothing. Its droppings and its scales are what are allergenic. So you don't always have to see the insect to know that you're allergic to it or have allergies to it. Another one that's very relevant in India, I've not mentioned here, but rats and mice. Their urine contains very, very potent allergenic proteins and can cause major issues for some people. Molds, the most ubiquitous, probably the widest spread and most unique of species that is there in every corner of the world. Pets, cats, dogs, birds, gerbils, hamsters, you name it. And then foods. Yes, foods can trigger rhinitis. There are very variety of ways in which a food can trigger rhinitis, but I have here in India, I used to think I would only see this abroad, but here in India, I have kids or even teenagers or adults who will say that if someone is preparing a food in the kitchen and they are in the home or they are in the kitchen while the food is being prepared, they will start having bouts of sneezing, which fortunately does not go to a systemic reaction always, but can and become anaphylaxis. But it's a systemic reaction that they're having to inhalant foods. Ingested foods can also trigger rhinitis in certain patients before it actually goes into urticaria, angioedema, breathing difficulty, changes in cardiovascular function, etc. One slide on the triggers of non-allergic rhinitis. Okay, this list is actually very, very brief. It can be even longer than this. And in a large majority of patients, what I find that they may have allergic rhinitis, but their non-allergic triggers are just as problematic as their allergic triggers are. So smoke, commonest one you and I would think of would be vehicular smoke. But smoke in homes in India can be a major issue, right from agarbatti, dhoop, to candles these days, fancy candles with a lot of fragrances, to having even the possibility of people still using mosquito coils, which if you all have not ever heard, produces smoke or PM 2.5, particulate matter 2.5, equal to almost 20 to 50 cigarettes in one mosquito coil, okay, in a closed environment. And then burning of stuff, which happens all the time. Spicy food. This is more like a vasomotor rhinitis, but layer it on top of it, an allergic rhinitis patient, they have a lot of trouble. Temperature changes, weather changes, cold, dry air. So these are again non-allergic triggers, affect allergic patients more, but can affect a patient who doesn't have allergies also, depending on their sensitivity. Viral infections, medications. I won't go into the list of medications. It will become a very long presentation by itself. We'll cover that possibly in drug allergies. It's a module later on. Perfumes and air fresheners. So anything with strong fragrances or even mild fragrances. I have patients who present to me. They don't present to me because they think they have allergies. They present to me because they say that I can't tolerate any smell. Any smell makes me unwell. Their actual problem is allergies. They have allergic rhinitis, but they're not coming to me because they're sneezing or having runny nose or a blocked nose. They're coming to me because they can't handle smells. Okay. This is how human beings are. They'll prioritize whatever they feel is relevant to their life and their lifestyle. Hormonal changes, again, won't go into details, but impacts more to women than men, as you would expect. And then stress, a big part of non-allergic triggers in rhinitis. As I said, stress impacts your nervous system. You have an afferent and efferent nervous pathway, which very, very strongly innervates your nose. Remember, your nose is one of the, what I would call, first exposures that the human body has to the environment with breathing, first breath, otherwise no life. And stress can actually make allergies worse. We have very good, elegant studies done in the US where they have shown that during examination, if you take medical students who have allergies, nasal allergies, and you take those same students when they don't have their exams, they're on vacation, and you happen to draw their blood, and in adults, they've even done challenges with allergens, aeroallergens. They found that when they are not under stress, when they are not under pressure, their symptoms are much less. How does this translate into your daily practice? Patients will come and tell you, Dr. Saab, Bombay में कुछ तो है, Bombay के बाहर जाता हूं, कुछ नहीं होता है. I have patients who literally, they're on nasal steroids, they're on antihistamines, they're on anti-leukotrienes. They go out of Mumbai and they stop all their drugs and they're still okay. There are many reasons to this. It is not only stress, but when you're on a vacation, you're happy, you're cheerful, you're enjoying yourself. You don't really get all those extra stimuli that your lining of your nose and your nerves require for you to have symptoms. I'm not going to again go into a lot into air pollution. I think I covered part of it in a previous presentation, also in a previous module, but it is a very big part again of how these, what I would call get layered on top of each other. One more reason why out of Mumbai they feel well. Pollution is much less. That's a major add-on. We know that if you have a pollen allergy and you just instill the pollen into a person's nose who has an allergy, let's say they get X amount of reaction. If you instill that same allergen with a diesel particle in the person's nose, they can get up to 40x reaction to that same pollen. These have been done in vitro. There have been some challenges also done combining these things together. But we cannot underestimate, given that Mumbai's air quality, in my opinion, in the last 4-5 years has really gone down. I don't know how many of you all would agree with me, but I've been living here also since my birth, went away for a little while, came back. But the kind of PM 2.5, PM 5, PM 10 we have, and on top of that, the other pollutants, which are gaseous pollutants, it's having a very bad impact on our nose, lungs. I'm sure you all have seen YouTube videos and Instagram videos where people who do lung surgery talk about having black lungs in non-smokers these days from a very young age. So I think we all as doctors, and this is we need to do this. We need to really wake up the system, wake up people and create a movement, because if nobody's going to do it. Trust me, because no one is invested in health as much as you and I are. So any opportunity you all get and any organizations you all are with, please take this up at a war footing. That's the least we can do for our future. Maybe in our lifetime, we will get impacted some, but our kids and our grandkids are really going to pay the price in the times to come. Let's come to the diagnosis of allergic rhinitis. Actually, it's not that hard. Can be hard if the presentation is weird, but you get a very detailed personal history, very detailed family history of focusing on allergies, and any kind of allergies. Doesn't have to be that the parents or grandparents have rhinitis only for the child or the grandchild to have rhinitis. They could have asthma, they could have atopic dermatitis, they could have food allergies. Anything that tells you that there is a atopy risk of developing a high IgE Th2 response. A very detailed environmental history is very important, because as we can expect, if we don't know what the person is living with in their home, we cannot really counsel them about what to avoid or what not to avoid or what to do. Once you have these details with you, your next step is the examination, which can be sometimes completely normal also. Okay, so I've had allergic rhinitis patients who have presented to me fairly early in their journey of allergic rhinitis and don't have necessarily the allergic shiners, which is the kind of vascular congestion that occurs below the eyes. They don't have the Denny Morgan lines, which is the transverse crease on their nose from rubbing their nose constantly, the nasal salute, the nasal cop, the pale boggy mucosa. The mucosa still looks pink and healthy, but it's the start of their disease. So again, you have to have a high level of suspicion in the presentation, the exposure, the timing of the symptoms, the nature. So in history, for example, if someone tells me every morning I wake up and I have a bunch of sneezes or my nose is blocked, which allergen anyone can guess will you think about in such a patient? House dust mites. So because that's a constant exposure all night long. That's what they're breathing from, their mattress, their pillow, if there are kids, they have soft toys. There are lots of things you can get it from. So little things like that, I've had patients who've had no nasal symptoms on waking up in the morning. The only thing that we could get from history was when they take out old clothes from the cupboard and dust them, they start sneezing. Again, dust mites. Okay, dust mites don't just stay in your bed, mattress, and pillow. They redistribute to every other part of your home. So history, like any other medical disease. Examination, mostly very helpful. Sometimes you don't find much. I've not put everything on here. They can have tonsillar hypertrophy. If they've had a lateral neck X-ray, you may see adenoid hypertrophy. They may have many other features. They may have chronic sinusitis symptoms. And the primary diagnostic system that you would use is allergy skin testing. We'll talk about that. And then where it's not possible or not practical, you would be doing specific IgE blood testing for allergies. Why should we test? Most people say, and it has been the work style in India, as I may say, you get a suspicion of allergies, you prescribe an antihistamine, you prescribe a nasal steroid, you have them use it. Most patients will use it on an as needed basis. They'll manage themselves. So why test? क्यों करने का? खाली पीली पैसा खर्चा करने का? Dust सब जगह है. These are stories I get from patients and sometimes from doctors. If you can identify or exclude the allergy, you can then start working on the real pathology or the triggers. You can guide optimal treatment. You can guide optimal referral if you're a primary care physician. You can be specific about identifying the offending allergen. So rather than, I cannot tell you how many hundreds and thousands of times I've seen this, but patient is suspected to have allergy. Patient is told, dust se dur raho. Dust se dur raho, patient says, kaise? Bombay mein rehte hum, dust se kaise dur rahe? Okay. Or they are told that don't eat these foods or don't have these things or don't get exposed to these things becomes very challenging. So the days of having generic advice given to allergic patients is no longer there. Your advice has to be tailored, customized, and has to be based on specific testing. The other reason why testing is important is when we look at the influence of anti-allergic therapies, we will see that most of them occur after contact with the allergen. No brainer, right? अगर contact ही नहीं हुआ allergen से तो symptoms कहाँ होंगे? तो फिर दवाइयाँ कहाँ जरूरत पड़ेगी? Immunotherapy is the only thing that works before contact with the allergen by altering your immune function. And allergen avoidance, which can be done only if you have the specific allergen known, and immunotherapy, both are dependent on allergy skin testing or allergy blood testing. Without it, you can't do them. So the two lines of treatment that go to the source of the problem are dependent on an accurate diagnosis. Without it, you can't proceed. So when we talk about in vitro testing, that's immunocap, or nowadays we have something called component resolved diagnostics or molecular diagnostics. And on skin test is the standard skin prick test, scratch test. There are different systems of doing it. Skin prick test is still considered the gold standard. I'm not going to read through all of this, but the World Allergy Organization, the European Academy of Allergy, Asthma and Clinical Immunology, the American Academy of Allergy, Asthma, Immunology, American College of Allergy, Asthma, Immunology, They all say that the clinical relevance of a skin test with the person's symptoms is higher than a blood test. What does that mean in short? A blood test can pick up a lot more false positives, whereas a skin test can pick up a lot more true positives for you. Having said that, some patients may not want to go through the skin testing. That rarely happens, but it does happen. Some patients may not have good skin on which they can be tested. They may have other conditions or issues. They may not be able to come off their antihistamines even for 48 to 72 hours for testing. So in those situations, blood test becomes important. And these are the merits and demerits of doing a blood test versus a skin test for allergy diagnosis. Remember that there's a whole module that's going to be dedicated to diagnostics later on. But in this, just to give you an idea, they both have high sensitivity and specificity, skin test and blood test. So no question about that, high reproducibility. One gives you a quantitative result, that's the blood test, whereas the skin test does not give you a quantitative, but we do quantify it compared to the negative control, which is buffered saline, and the positive control, which is histamine. So we do measure and calculate it related to that. WHO standardization is there only for the blood test, can't be for the skin test. Quality assurance programs are there for the blood tests. Blood tests can be given regardless of medications. Person could be on antihistamines every single day, even 3 times a day, and you can still do a blood test. You cannot do a skin test. You have to stop the antihistamines, sometimes even tricyclic antidepressants. There are other drugs that can interfere with skin testing, so you have to monitor that. Regardless of how the patient's skin is doing. So some patients have a lot of atopic dermatitis. There's no place on the skin to do skin testing. They have eczema everywhere. Their blood test becomes invaluable. Report time takes 1 to 3 days with the blood. With skin, it is much faster. You can read it within 20 minutes. Cost factor. Blood testing is more expensive done correctly. Now, there are a lot of spurious blood tests in India. Lot of them, okay? Which will charge you anywhere from 4,000 to 6,000 or 8,000 or sometimes 9,000 rupees and give you what I would call a completely bogus report. And you have no way of verifying or confirming it unless you do some other form of testing. Now, I cannot publicly say what these are. If you all are interested, I'll be happy to talk to you later. But also, when a person himself is not an allergist and is not himself reading the allergy test, and there's some technician doing the test and reading the test, it becomes a problem. Okay, that's not the way allergies are diagnosed anywhere else in the world, where a technician does the reading, unless the technician has been formally trained by an allergist, okay? And even if they're trained by an allergist, I get a lot of these commercial people who are doing tests. They're sending them to doctors' offices, even sometimes to homes. I don't know how. But you look at the report and the person has dermatographism. So like 40 things are positive out of 100 on their allergy test. That can never, ever happen in the field of allergy. Even with cross-reactivity, the chance of getting those many positive does not exist. And sometimes it is just numbers that are written, and all the numbers are 3, 4, 3, 4, 3, 4. Buffered saline is also 2, 3. Histamine is also 3, 4, 5. It's like impossible to interpret. I don't know what they're trying to do in that report, but this has become a huge problem in India now. So please be aware of it. And be sure that where you are sending is a reliable place with reliable people and reliable ways of interpreting the test. And on the blood test also, know what those spurious labs are which give you spurious reports, especially if you see a lab that gives you blood allergy test to 20 drugs or 30 drugs. You can assume that that report is not real. Because as an allergist, I can tell you there are no 20 or 30 blood tests for drug allergies. Doesn't exist even in America or Europe at this point of time. Okay. When a person sees a big wheal and flare on their arm or their forearm, okay, they have motivation. They realize what this is doing to them. You give them a number on the blood test, आपका allergy 3 आया, 5 आया, 50 आया, 100 आया. They don't know what it means. They will just have to go with your word कि 100 बहुत high है, 50 भी बहुत high है, 3 moderate है. But when they see a reaction, so skin testing is still by all standards. And you may say I'm biased because I'm an allergist. It's not like that. I've been doing this for too long to know the pros and cons of both of them. Skin test is the way to go when it comes to diagnosing allergies. Once you have reached a diagnosis, okay, through the right choice of tests. Now, I can't really go through every single allergen and all. That will all happen in the diagnostic module that I'll take over, okay? So if you all are thinking that I'm skipping a few things, I'm not intentionally skipping it. We have a lot to cover still in this module itself. So in the management, we're looking at allergen avoidance. That's the primary thing that you can do. It does make a difference. You're looking at patient education. This is a huge thing that lacks. I see people who get the right report, they get the right test done, but nobody's counseled them about what that report means, because many a times the doctors themselves are not trained to know what a CRD is showing or what a immunocap is showing or what the allergy skin test relevance is in some cases. And I think that this is something that we all have to educate ourselves about, because we will get more and more patients bringing these reports to us. Pharmacotherapy has been the gold standard. Immunotherapy is very effective with a specialist doing it, can really change the life of a person. I've selected one allergen as an example, house dust mite, because as you know, if you take 100 allergic people in India, 70 of them will have a house dust mite allergy. That's how high the prevalence is. In all tropical countries in the world, this is the number one allergen. In Europe, maybe they'll say pollens are the number one allergen. US, they'll say it's between dust mite, pollen, molds. Australia, they'll say dust mite is in the top 3 or 4. It varies, but these 3 dust mites, Dermatophagoides, Fahrenheit, Terranicinus, and Blumia tropicalis, make up the large majority of allergies that we see in India. Of this, the 2 that I've highlighted or bolded, I know it's not showing up very well, but washing the bed linen, bed sheet, pillow cover, the sheets on the body in hot water once a week, and encasing the mattress, pillow, sheets in what we call a dust mite proof encasing are the only 2 things that have been conclusively shown in research to make a difference to a person's symptoms. Everything else that I've mentioned here, provide ventilation, decrease humidity, dispose old bedding, remove carpets, remove curtains, pets, stuffed toys, they all make a difference. But studies can't always document or quantify the effect. They do make an effect. It's not that they don't, otherwise they wouldn't be on my slide. Using a vacuum cleaner with HEPA filter, that's one of the first thing my patients want to do. I tell them dust mite allergens are heavy allergens. They are settled. For an air purifier to work, it pulls air in. So if it's not airborne, what is it going to pull in and clear? Can't do anything for the most part. Unless आप यहाँ पे झाड़ू मारे और वहाँ पे full अपना purifier चालू किया कि जो उड़ेगा वो खींच लेगा, ऐसा होता नहीं है. Point being that these are all supportive processes. The focus needs to be on what I have mentioned. This is one I've not gone through all the other allergens. We'll go in more detail. Once you've done the allergen avoidance, the management focuses on your classification. Now, patients do not follow guidelines, correct? We as doctors also don't follow guidelines, which is good sometimes, because neither of us have read a book and come. Patient भी book पढ़ के नहीं आया है कि मेरा mild intermittent होना चाहिए, mild persistent होना चाहिए. They jump, they change seasons, they get sick, they have problems. In one season, they'll be moderate, severe, persistent. In another season, they'll be mild, intermittent. So you really need to tailor and taper the therapy according to that. And as you can see, in anyone who's moderate to severe, intermittent, or mild or moderate persistent, intranasal steroids are the gold standards. Oral non-sedative antihistamines, which are the H1 blockers, which are the second generation H1 blockers, are the key. Decongestants for short periods of time, I've said 10 days, actually we don't go beyond 5 or 7 days. Oral decongestants, we have some good options in the market right now, which are combined with antihistamines, leukotriene receptor antagonists, and then avoidance of the allergens and immunotherapy in, as you can see, even moderate to severe intermittent, which would be a classic pollen allergic patient. I get patients even from Kashmir who come down to us and they have allergies to birch pollen and willow pollen and certain other trees. They're very severe symptoms for 2-3 months. And even in them, immunotherapy can be life-changing, though they have seasonal allergies. So knowing these indications is very, very helpful. When you look at the drug choices, it's important to know what each of these drugs can do. So your antihistamines will impact the sneezing and the itching very well. They'll impact the rhinorrhea decently, but congestion they can't do much for. Anticholinergics, which we don't have in India right now, impact only the rhinorrhea. The corticosteroids can impact all four of them, and hence they happen to be the gold standard of treatment. Decongestants will only work on the rhinorrhea to some extent and largely on the congestion. Mast cell stabilizers, again, we don't have too much of that. We have them for the eyes, but not for the nose. And the anti-leukotrienes, as you can see, again, sneezing, itching, they do work on congestion some. I think 4+ may be a bit too much, maybe 3+, because they don't work as much as corticosteroids or decongestants can. And when you look at the algorithm for treatment of allergic rhinitis, you'll see that you have to check every single patient with allergic rhinitis for asthma. Okay, this is something that is an unwritten rule. Even if my patient has zero symptoms of asthma, whether they are a child who can do a PFT or a forced oscillometry test or an adult, they all get a screening test, because in my career, probably I would say 20% of the people who see me with allergic rhinitis have asthma and they don't know they have it. Okay, that's a high number for me. The other 20% know they have it, but have had not much going on with it. So when you tell them and show them the numbers, they actually want to do something about it. And they become more clear that they need to do something about it. Now, anyone with moderate to severe, I would say you should be checking for asthma. If they have intermittent symptoms and it's mild, you're going to use the antihistamines, you're going to use a decongestant, you may use an LTRA. If they are moderate to severe or mild persistent, you will use nasal steroids, you will use antihistamines, the non-sedating ones, LTRAs. No preferred order, as has been said here. Patient preference also is very important. If they are better in 2 to 4 weeks, then you step down the treatment. If they are not better, then you step up the treatment. You want to definitely continue treatment for a month. You don't want to stop it suddenly. That's a bad idea. You want to taper it. And then moderate to severe, you will start with a nasal corticosteroid with an H1 or an LTRA or sometimes both. Review in a few weeks, improving, step down, not improving. You need to refer them to a specialist if you're not a specialist. So if you're not an ENT specialist or an allergist, and this is not your routine thing, at that level, you need to be considering sending them somewhere where they can be evaluated for further potential, what I would call comorbidities, complications, etc., because of which they're not responding. Leukotrienes have a very important role. I again won't get into this in great detail. I had the slide, so I put it in here. There are multiple mechanisms by which they influence these diseases. They weren't originally designed, when Montelukast was first studied, it was actually studied as an anti-asthmatic drug. Then they figured out that all the benefits in the lipoxygenase pathway actually works very well in allergies. It has an influence on eosinophils. Started working on that aspect. Now it is used for both, as we know. So when you have patients who have overlap of asthma and allergies, this happens to be allergic rhinitis. That happens to be a decently good molecule. If there are questions, we'll deal with it later related to this. Now, this is a very important study, which was called the Allergies in America Executive Survey, where they looked at almost 2,500 patients, asked them, and most of these were on some treatment. So these were not people who were not taking medication. They were taking medications, and they were asked that every day or on most days, did you have a blocked nose, postnasal drip, sneezing, runny nose, itching? You can see that anywhere from 30% to 60% people said that despite being on medications, they were still symptomatic. And 69% patients said that they were treated within the last 4 weeks, 45% with prescription drugs. There are a lot of drugs available over the counter in America that you can buy just off the shelf. You don't have to go to the doctor and buy it. Okay. Allegra, some of the other products very easily available. So that brings us to the point of doing immunotherapy. Again, there's a whole module dedicated to immunotherapy. I think it's module number 10 or 11, if I'm not mistaken. We're going to deal with that in great detail, but this therapy has been around for almost 114 years. The first paper was published in Lancet, so it wasn't any era-gera journal. Very good study. 1911, worked on Timothy grass and showed that within a couple of months of starting injectable immunotherapy, what's called subcutaneous immunotherapy, the chance of having symptoms during the pollen season reduced dramatically is the right word. Okay. Allergen immunotherapy is a process where we are administering gradually increasing quantities of the allergens. Some people call it a vaccine in some parts of the world, but quite You will wonder कौन सा वैक्सीन रोज लेना पड़ता है या हर महीने लेना पड़ता है. वैक्सीन नॉर्मली लेते हैं, बूस्टर लेते हैं, खत्म हो जाता है. So I don't use the word vaccine, but it works like a vaccine. It kind of desensitizes you in some ways. You reach an effective dose, you ameliorate the symptoms with subsequent exposure to the allergen. The mechanisms of immunotherapy, again, I'm not going to go into it, but every aspect of a patient's life, right from quality of life to symptoms to medications to skin test reactivity, everything can be influenced. There are almost 12 different mechanisms by which allergen immunotherapy works. It can be oral or injectable. Symptoms get better within 6 months to 1 year, but the duration of therapy has to be 3 years. Okay. Again, this is an area I will talk to you in a bit about what the issues are with the way immunotherapy is being done in India. You reduce exacerbations, you reduce the number of steroids that are required, whether they are nasal steroids, whether they are inhaled steroids, whether they are ICS, LABA. You can alter the natural course. So a child who has allergic rhinitis, the risk of developing asthma is close to 40%. Population risk is around 5-6%. You can reduce that risk by up to 60 to 80% if you do immunotherapy in that child at the right time. So they don't go on to developing allergic asthma in the future. In adults also, there is good data to show you can prevent new allergies developing. Once you have allergy to one substance in the environment, you can develop to others. Okay, that's called expansion of your molecular range of allergies. It's safe and efficacious as long as it's done by a trained person who knows how to manage. It prevents, as I said, development of new sensitivities, alters the natural history, so both the WHO, the allergy organizations, even the Otolaryngology Organization of America says that this is the way to go when it comes to treating diseases. Subcutaneous is the injectable one, sublingual is the one under the tongue. Subcutaneous was the only one approved in India for the longest time. Sublingual was done off label. And I'll speak about that in a second, but they've shown that you can reduce symptoms, you can prevent progression, you can, if there are patients who are failing to respond to the therapy or getting side effects from the drugs, or they choose not to be on drugs for long-term periods of time, patient choice and preference to be medication-free, these are all reasons where you would do immunotherapy. More details later. Allergic rhinoconjunctivitis and allergic asthma are the top indication. You need to have not just sensitization, which means a positive test. You need to have a correlation with the symptoms of the person for you to do immunotherapy to a person. And then there should be a available standardized allergen extract to do the immunotherapy with, so you get the results you desire. Now, very recently, I've been working with one of the pharma companies in India. We have a sublingual tablet available for house dust mite allergy. I won't go into details because this is a very potent product. There is a risk of systemic and local reactions. But it's very good to know that finally sublingual immunotherapy has come into India, where so far it was all being done off label. But this is a DCGI approved, FDA approved product, which we now have. An important slide for me in this topic when I'm discussing allergic rhinosinusitis is what are the dangers with immunotherapy in India. Okay. As I said, immunotherapy based on erroneous blood tests or skin tests, which means you're giving someone immunotherapy for 1 year, 2 years, 3 years, and you're not actually made a proper diagnosis because your test is not accurate or your test is not matched with the person's symptoms. I know labs which will give you a report. They don't know the patient and they will say, we'll provide you immunotherapy. Just tell us. And I'm like, you don't know the patient. You don't know the patient's history. How are you going to provide immunotherapy to this person? Because a positive test is not an allergy. A positive test is only sensitization. If you get symptoms on exposure to that allergen, then it's an allergy. And the lab, without knowing the patient, without knowing the doctor, happily says, I will provide immunotherapy to your patient. It will come to your house. Please beware. नाम खराब होता है कि थेरेपी काम नहीं करता. गलत आदमी को दोगे तो काम ही नहीं करेगा ना, कैसे करेगा? Quality of extracts, batch to batch variation, non-standardized extracts. It's an issue. Not much we can do. We are getting standardized ones gradually with this, as I said, sublingual tablet coming now. There'll be more in the future. But we work with what we have and we get decent results. People don't have confidence in writing the immunotherapy formula or mixing the allergens. So I teach at several of the major training programs in allergy in India. And even after a full 1 year intermittent contact program that we have, people don't have a confidence to select the allergens, how much to put into the mixture, what to do. You're dependent on a company. The company doesn't know your patient. The company doesn't know your patient's symptoms. In anywhere else in the world, there is some degree of customization that the doctor does to the immunotherapy mixes for their patient. Ready-made formulas are used here. Suboptimal local seasonal allergen relevance to clinical symptomatology. What I mean by that is we don't have great pollen calendars for India. We don't have all the local allergens represented in testing. If we have them, they're not highly standardized extracts, and immunotherapy becomes a bit challenging in these situations. Food allergen immunotherapy is being done by people. You know, a food skin test comes positive or a blood test comes positive, people put them on immunotherapy. Food allergen immunotherapy is not indicated for anyone who has just a positive skin test. There are very specific ways it is considered experimental. There is only one food desensitization product in all of America, and that is to peanut, called Palforzia. Okay. And in India, I find people writing sublingual immunotherapy. I've even seen injectable immunotherapy, which can give anaphylaxis and kill people if someone actually has a serious allergy to a food. I've seen that happen left, right, and center. Very scary. Incorrect dosing, amount of allergen put in is not right. Incorrect duration. Non-allergists who are prescribing immunotherapy can be an issue. Can be even become a medical legal issue. Incorrect duration. People are told, you know, when you tell them it's a 3-year treatment, the natural response is, "Arey, bahut time hai, nahi karna hai." So what do people do? "Arey, chinta mat karo, 6 mahina karo, ho jayega tumhara." 6 months you can't desensitize someone. I've never seen it happen. Okay. "Arey, 1 saal karo, ho jayega. 2 saal karo, ho jayega." You see what I'm saying? This is all off the top of your head. Say what you want to rope in a patient kind of practice. Very, very bad. नाम खराब होता है फिर से. Patients को लगता है ये waste था, हुआ नहीं काम, ठीक नहीं हुआ, allergen भी गलत, patient भी गलत, duration भी गलत. I see that every single day in my practice. So there's loss of faith amongst the physicians who have sent for the immunotherapy and amongst the patients who have taken the immunotherapy. This thing is bogus, and that's why in India it got a bad name. When I came, there was a lot of resistance, but now I'm very happy that we have about 1,200 allergists that we've trained in India through the various training programs, and the message is spreading and people are starting to trust it again, believe it again. Done correctly, it is an effective treatment. Is not required for every single person who has allergies. Please take that as a very important statement. Not everyone who has allergies needs immunotherapy. Okay. Poor adherence regimens. Patients are not used to treating nasal allergies as a chronic disease. उनके हिसाब से आता है, जाता है, दवाई लिया, बात खत्म. People want quick fixes. So there's a lot of education that you have to do before doing immunotherapy. So SCIT and SLIT, that subcutaneous immunotherapy, sublingual immunotherapy, should be prescribed by people who have training in allergy and with practical experience under careful supervision, using the best available quality of extracts for the right duration of time and with the appropriate consent. It's a very, very powerful treatment. Immunotherapy right now is primarily used for secondary prevention, which means someone has allergies, they have nasal allergies or they have allergic asthma, and we're trying to prevent progression. We're trying to prevent allergic rhinitis going to allergic asthma. We're trying to prevent a person having 2-3 allergies from having 8 or 10 allergies after a few years. So that's secondary prevention. It could potentially be used for tertiary prevention, where you want to prevent the development of asthma symptoms in someone who already has changes in their lungs occurring or having some symptoms. And then this would be the holy grail, and there's actually research going on this, where you take healthy but at-risk children and you give them immunotherapy and see if you can prevent the development of allergies to begin with. There is research going on this in some parts of the world. We'll come to rhinosinusitis. I'm not going to spend a whole lot of time on this. I wanted to put it in there because it goes hand in hand with allergic rhinitis, and this is the best module to include it in. But rhinosinusitis, so allergic rhinitis is inflammation of the nasal passage. When the sinuses also get inflamed, that's called rhinosinusitis. It's preferred to calling it only sinusitis because only sinusitis very rarely happens. You almost always have some rhinitis with it. In the US population, up to 12% are believed to be affected. In India, we really don't have that kind of very good large population data to give numbers. But acute rhinosinusitis, which can be mostly bacterial, viral, infectious in nature, is not what I'm talking about. It's more the chronic rhinosinusitis where the symptoms have been there for longer than 12 weeks. And 2 or more of the following symptoms have been there, including nasal discharge, nasal obstruction or congestion, reduced smell, facial pain or pressure, cough, especially in pediatric, And one of the objective findings, which is inflammation on endoscopy or CT scan, and purulence coming from the paranasal sinuses osteometrial complex. And these are then divided into with polyps or without polyps based on the absence or presence of polyps. This is just a further description of the same slide. I'm not going to go into that. Very quickly, when we come to therapy for allergic rhinosinusitis, we are primarily looking at using topical medications such as nasal steroids. Sometimes short-term oral steroids are very beneficial. Saline irrigations, what used to be Jal Neti in ancient India, is now made into sinus rinse kits, can be invaluable. You can even prevent surgeries or repeat surgeries in people if you use it correctly. Antibiotics, if they have an acute exacerbation. This is something, aspirin desensitization. We don't do enough of this in India, but if anyone has heard of something called the Samter's triad, where you have polyps in the nose, asthma, and you have aspirin sensitivity, these people's lives can change if you admit them to a hospital with an ICU backup and do aspirin desensitization. Even chronic rhinosinusitis with polyps can have a huge impact. Biologic therapies, including omalizumab, now even other things like dupilumab, in some situations, mepolizumab benralizumab have been shown to have a very good impact, especially when you have had a patient who required surgery and then you put them on biologics for preventing recurrence. Otherwise, some of these sinusitis patients have back to back to back over years, multiple surgeries going on. And then FES to be considered. So when you do medical therapy for chronic rhinosinusitis without complications, you're talking of 2 to 3 weeks of antibiotics. This is another thing that I find a lot of people failing to do in India. They give 5 and 7 days of antibiotics. If you're making a diagnosis of sinusitis, you need nothing short of 14 days. Okay? 14 days. I'm not making this up. Go and read it up if you want. 4 weeks of nasal steroids, 4 weeks of saline irrigations. You might be able to prevent surgical interventions in these people. If you're getting with polyps, then you may want to even add an oral taper of nasal corticosteroids in these patients, along with all the 3 things that I mentioned before. If despite of this, it doesn't happen, then you're talking about surgery. Surgery could be FES, it could be some turbinate reductions or turbinoplasties. It could be, if they have bad DNS with it, they may need correction for that. If you have a lot of non-allergic rhinitis along with these problems, there are surgeries that work on the posterior nasal nerve. There are many unique things that are done. There are different types of cryotherapies. There are different type of radiotherapies that are now done. I'm not going to go into all of that. This is not the purpose of this topic. That's more of my ENT colleagues' job. But there's a lot that we do where we co-manage these patients with our ENT colleagues. And that's how I think it should be done. They do the surgery, they do the acute management, we do the immunotherapy part, we do the long-term management, we co-refer, co-manage with them. That's how we used to do it in America. Allergic rhinosinusitis is a very common problem. As you've seen, it affects everything from your sleep to your sexual life and everything else in between. Very good immunotherapy and pharmacotherapy is available. Genuine allergy testing, that's the key word, is necessary to do right immunotherapy. As physicians, we should take time to assess these patients and impact of the disease on their life and provide a customized multidisciplinary line of treatment for these people. As I told you, stress is my passion, not giving stress to people, but reducing stress in people's lives. Okay, whether it's my patients or my fellow colleague doctors, we as doctors, as we all know, tend to take more stress than the rest of the world because our life has their usual stressors that everyone has. Home, family, finance, everything else, medical, legal. But on top of that, we take anywhere between 5, 10, 20, 50 patients stress also upon ourselves. And they expect a lot out of us. And unfortunately, in our entire medical training, and this is from personal experience I'm talking, nobody ever taught us how to deal with that or what to do in order to address that. Okay. So I started a journey myself when I was in second year of MBBS, because I knew that modern medical science has very good control for a lot of things, but very little cure for a lot of things. If anyone disagrees with me, meet me later, we'll talk about it, except for surgical specialties and where you get rid of something, or antibiotics where you get rid of something, or certain ICU situations which are very critical. In most cases, we are just putting out the fire temporarily and hoping that the fire stops on its own. So I started looking at alternative sciences, and I found that the mind-body connect, or the mind-body-spirit connect, which even in allergic rhinitis, as I told you, it's well proven now that if a mother has stress during pregnancy, what we call perceived stress, the chance of her baby having atopic dermatitis or having wheezing in the first year of life skyrockets. Well done research more than once. If a research is only done once, then never ever believe it. If it's repeated by someone, then believe it, because it has to be reproducible. Because I can bias and do any research you give me with the right statistics. I know how it is done. But when it's reproducible by different groups and which has been shown, I think everyone here will agree that allergic rhinitis gets worse by stress, asthma gets worse by stress, atopic dermatitis gets worse by stress, chronic urticaria for sure gets worse by stress, urticaria with angioedema gets worse by stress. Now I'll take this forward to cardiac diseases, hypertension, diabetes, you name a disease and it gets affected by stress. We think stress is only mental. Stress can be physical, it can be biochemical, what we eat and drink, what we are exposed to, pollution. Stress can be mental, psychological, emotional, and then there's something called etheric stress, astral stress, spiritual stress. We won't get into that part today. But as my interest, which very interestingly Hetero understood that I have a very deep interest, I actually published the first textbook chapter on stress and allergic diseases in a very big textbook. There's a 2-volume, itna jada 2 volume hai. 30 page ka chapter tha ya 28 pages ka, called Stress and Allergic Diseases, the Connection, with all the intricate mechanisms and everything while I was in the US. Along with my mentor, Dr. Galen Marshall, I had done that. But problem hai, bata ke koi matlab nahi hai. We need a solution to it, some answer to it. So real prevention, I actually work in my clinic with people through their dietary changes, lifestyle changes, through different types of what people may call de-stressing, because I truly believe that we are what we eat, everything that we go through. And I tell this to my patients also, because some of them have problems where just medications is not going to solve it. And what I'm telling you now is not so much for your patients as much as it is for yourself, because each of us needs to look at our lives more closely about what we are doing, how we are doing, where we are doing, and where we could be doing better, so that we take care of ourselves. हम लोग पूरी दुनिया का ख्याल रखते हैं, हमारा ख्याल कौन रखता है? खुद नहीं रखेंगे तो कौन रखेगा? I do programs, I do camps. They happen in India also. This is in the US. I go and do this. I still go back to the US primarily for this reason. And I do camps. And very recently with Hetero, for the first time, we did this program called Healthy Living Workshop for Doctors. Full day, starting at 9 in the morning till about 4:35 in the evening. Doctors were with me and my team, and we were working on first letting them identify what the problems are in their life, because we have never taken time to do that, okay? And then where the problems are, what you can do about it through different techniques and methods. And I would want to share a half-a-minute video with you all. Do you all want to see the video of the camp that we did? Yeah? Okay. Can we please play the video? So a very brief overview. This is not the whole thing, obviously. It was a full day's thing, but right from understanding, as I said, we had questionnaires that the doctors did on their own. I don't want to know your answers, to identify where the issues are, what they are facing, to how to handle it with simple changes in your day-to-day life, simple changes in diet, in lifestyle, in some basic things you can do lying in your bed, or just waking up in the morning, or going to sleep at night, or through the day, which will really cut down your stressors. Because if we take good care of ourselves, only then we can think of taking good care of others. Otherwise, at one point of time, we have worked, and we disappear. And the end to patients or number of patients or the number of problems is never going to come. So just my sincere request and wish to all of y'all that take time to take care of yourselves, because that's very, very important. Today, y'all are here because you'll want to learn about the disease and take better care of your patients. Sometimes take time out and do something for your own self. Thank you very much, and you'll have a wonderful day. We'll take questions now, both here and from the different locations that we are broadcasting at.
Am I audible?
Yes.
Sir, what would be dose of in a case where you mentioned macrolides at least for a duration of 2 weeks? So the commonly used is today is azithromycin. So what should be the dose?
Very interesting question. There are two ways to do this. One, you don't choose azithromycin, you choose clarithromycin. You can give that for longer. Azithro accumulates, as you know, in the tissues, hence they say 5 to 6 days, then you take a gap. Studies have been done where it's been given for longer, but the way we used to do it before, we knew more data, was we gave 5 days on, 5 days off, then 5 days on again. And you get the same effect as giving 2 weeks of a continuous antibiotic. I prefer going to clarithromycin. If I'm going to use a macrolide for chronic sinusitis, I don't use azithromycin, I use clarithromycin. I hope that answers your question. Yes, please.
Regarding the hygiene,
Can you please take the mic?
Uh,
You're
is there-
asking about
is-
anti-IgE.
Yes,
Yeah.
yes, sir. Is there any guidelines? What should be IgE level, or does it depend on IgE level or any parameter, or in fact data?
Yes. So there's very good data. And in fact, the company recommendation is that if your total IgE is around 700 or lower, is where anti-IgE would work best at the standard dosing, which goes up to about 450 milligrams every 15 days. That's the max dosing officially given by the company that did the original research. However, you have to remember that in India, generally people's IgE levels are quite high. It's not unusual to get 1,000, 1,200, 1,500, 2,000. So there you really have to use it with a little bit of what I would call thought process involved. I have used anti-IgE in patients with IgE levels above 700 also. Some people use up to 1,000 without thinking too much at the same dosages that we use for 700 or even 1,200. But the goal is that you need to see a response to the therapy. And what ends up happening, I think omalizumab in some ways became a highly misused drug in India, in my opinion. It was like, deke dekhte hain, kaam hota hai kya? That's not how it's supposed to be used. You have 3 criteria to give omalizumab to someone. One, they need to have a perennial allergy sensitization. I know lots of people who got omalizumab without ever having an allergy test, skin or blood. Just deke dekhte hain. Wrong choice. Okay. The second was, obviously, there are other indications where it's not required, like in chronic urticaria, you don't need to have a perennial allergen. But I'm saying originally, when we are talking about allergic asthma, which was the original indication, IgE levels were 5,000 and the person was giving 3 months, deke dekhte hain, thoda kam ho jayega problem. Okay. So choice of patients is very important. The cutoff is 700 officially. There are certain conditions in which the dosage can be modified, and I know people who have given higher dosages than is recommended by the company because either the person's body weight was too much. Combined, there are 2 factors. So body weight and IgE both have to be looked at to dose. So if someone is 120 kilograms, which would be like 240 pounds or plus, and their IgE level is, let's say 500, that person will technically not fit into any of the criteria for giving omalizumab because you'll need a much higher dose than recommended. Now, whether you do an off-label dose or not is something you and the patient discuss, okay? But there are limits through which we work and we don't go overboard, because giving someone 3 injections every 15 days already is a lot. But there are guidelines and there is cutoff.
You spoke
Yes.
of
allergy testing and why it would not be good for the company people to just do it, as a blanket. So what would be your protocol when you do it or you get a technician trained to do it? How many allergens do you normally test for? Is there a pro forma or is there a format that you follow?
Yes. So I have a list of allergens that I do for almost all of my patients who are above a certain age. For the pediatrics, I customize because there are limits to how many tests you can do. So I may do 30 odd allergen testing in a kid. I may do up to 60 odd allergens in an adult. When I see people doing 200 allergens, 150 allergens, I trained at a place called National Jewish Medical and Research Center. It's called National Jewish Health. It's considered one of the premier allergy institutes in America. We were taught that you do not test for more than these many, 50, 60 allergens, 70 allergens. Because the more you test, you're going to get a lot of false positives. You're going to get a lot of erroneous results. If you have dermatographism and the person is reacting at multiple sites, you're now left with ridiculous reports, which I see almost every week in my practice from other places. So the answer is you need to do limited allergy testing. And in fact, Europe has become minimalistic now. They have cut down on the number of allergens, they've cut down on the number of tests, and they are going even minimal. They may do 25, 30, 40. If you don't include the foods, if you include the foods, there may be more that they do. But the idea is that you do stuff that is relevant for your region, for your area in terms of pollens, etc. Relevant for the foods that are relevant to what people in your region are eating. Relevant to the patient's history. So not everyone needs the same panel, which is how these labs or commercial enterprises will do. It's like a gada ghoda, everyone gets the same thing. It doesn't matter kaun hai, kya hai, kaisa hai. Sabko ek hi panel milta hai. So customization is the key, interpretation is important, and after the test, a back correlation with sitting with the patient and correlating it with their history is critical for that test to be relevant and important.
So very quick follow-up question, and thanks for the answer. The customization, yes. And so I was recently told that there should at least be a 2 centimeter gap when doing a skin prick test between two allergens to avoid cross-reactivity, etc. What is your thought on that?
So the golden rule when we are taught allergy skin testing is having a distance of 2 centimeters, but you'll see a lot of people who do allergy tests do not keep that distance.
And it wouldn't be possible even with 30, 40 allergens. I mean,
correct. So in this process, what you have to know is a good allergist knows that you can do skin testing on the forearms. You can also do on the upper back, the upper 1/3 or half of the back. So depending on how many allergens you're doing, you can split between two locations. There are some people who also do it on different days. So they may do the aero allergens on one day and the food allergens on another day. I'm not judging that. I try to do it. See, for me, I know when one allergen has bled into another allergen and given a positive, because that's the concern. If they're too close by and you get a big wheel and flare to one, the other one will also look positive when it is actually not an allergy. So I think in this, there is expertise, experience, process, training your technicians so that they know what kind of a distance works for the type of testing you're doing, the potency of the allergens. Some of the allergens we use in the Indian manufacturers don't give very, very big reactions unless someone has severe allergies. So I think somewhere you have to go between practicality and what is ideal. And the answer lies within that. Sometimes you have to, so I see people using even the legs for doing allergy skin testing. That's never taught to us. But once in a while, if I had to go from the forearms a little bit onto the upper arm, I would. If I had to go to the back, I would. I can get most of what I need done in that much space.
Okay, thank you.
Thank you.
Yeah, one question from Ahmedabad, sir, please.
We have, yeah, please go ahead.
Sir, I'm Dr. Jignat from Ahmedabad. And what will be the time period to be kept to stop antihistamine and in patients on antihistamine plus steroid to go for allergy test? Means washout period, what should be there before going to allergy testing?
Okay. So the first question was, how long can antihistamines be given to a patient? Was that the first question?
Before going to allergy test,
when to stop the antihistamines? Ideally for 72 hours. That's the usual recommendation. If you have to go very strictly by the guidelines, they say 7 days for the second generation long-acting antihistamines. But my experience says that 72 hours is enough to stop the antihistamines to get a good, clean picture. If you ever have a doubt, what we do is we place a histamine and a saline control. Okay. And if the histamine comes strongly positive and the saline comes negative, then we can proceed with the testing. If the histamine is subdued or not coming very strongly positive, then there's probably something still in the system. And patients will often take cough syrups and cold syrups and something else that they were given by some other doctor that they don't know what's in that tablet, and all that interferes. So we fairly often will do a control test before we place an allergy test, because after placing 50 allergens, if you tell the person, sorry, the test did not happen, then they are not very happy. So, but the ideal duration is 72 hours if you can stop the antihistamines. Steroids need to be stopped depending on how long you've been on it for. So if you've been on it for only a week or 10 days, then they say 2 weeks off is enough to do the skin testing. Some may even say a week off is enough to do skin testing because the effect does not last that long. If you're on chronic oral steroids, then the impact on the skin testing is higher and it becomes a little challenging at times, especially if they are routinely taking it. If you stop it for just 3 or 5 days or 7 days, you may still have an impact on the result. And in such situations, you may want to consider limited skin testing or going in for a specific IgE or a CRD blood test in such situations.
Thank you very much, sir. Thank you.
Sure.
Another one question, sir, from Ahmedabad. Just a minute.
Can we make sure that we take he's been waiting for a while. Yeah, go ahead, please.
Good afternoon, sir.
Good afternoon.
Wanted to ask about clarithromycin, which is usually given in adults. It's either a 250 milligram BD dose or a 500 milligram BD dose. So which do you prefer in which cases? And the second part for the same was that clarithromycin is known to have cardiac complications, like it causes arrhythmia and QT prolongations. So would you recommend that in a patient with some cardiac history, or is hypertensive, or is geriatric, or do you change the antibiotic, or do you decrease the dose in such cases?
So regarding the choice of clarithromycin and the duration, when it comes to a patient and a selection, whether that is the right drug, remember there are other options. So you can even do an amoxicillin clavulanic for 14 days and get a decent coverage if the person doesn't have very strong history of taking multiple rounds of antibiotics. As was mentioned on that paper in the US, they like doxycycline also. So when you have an option, you use those. The dosage used generally is 500 BID, not 250 BID. And because if you're thinking of knocking out a bacteria that you feel is chronically there, remember they form biofilms and they do a lot of stuff that is not good within the sinuses. And so in that situation, you want to give a good dose for a decent period of time. As you saw, 2 to 3 weeks, I'm still saying 2 weeks. Coming to the QT prolongation, remember that some of the other drugs that the patient may be on may also influence the QT interval. So you need to know what other antihistamines, etc., they are on, and on what kind of cardiac issues they have. And if you have a reason for concern, then I would not use clarithromycin. I would use a different drug. We have several choices. I've only mentioned 2. People have used, in some situations, even the quinolones for treatment of chronic sinusitis. Those are considered next line, not the first line. But you try to find what is the safest option for your patient, looking at their entire medical history. I hope that answers your question.
Thank you, sir. Thank you, sir.
Yeah. We have a question here, just a
yeah.
second, in Mumbai, and I'll come back to whoever is waiting online. We'll get everyone, don't worry. I don't end the session because a certain time has happened. So be patient. I'll come to you. Please go ahead.
Yeah,
From Hyderabad, we have one question.
Just hold on. Just hold on. We have a question in Mumbai. Please hear. We'll come to Hyderabad in just a minute.
A few questions related to pediatrics. In your experience, what is the youngest kids whom have required immunotherapy which you have given?
Wow.
And what are the common indications in pediatrics?
Okay.
And second, any experience with cow milk protein allergy? It usually goes off with age in most of the cases. But in your experience, you have any with cow milk protein allergy? And the last
Somebody
is,
write these down. I'll forget by the end. बहुत सारे सवाल है. Koi please likho serious. I'm serious about it.
Yeah,
Or I'll make you repeat it. Can we do one question at a time? Is that okay?
Yeah.
All right. What was the first question? See, I forgot already because I'm listening so carefully to you.
pediatrics, your experience with
What is the youngest
immunotherapy,
immunotherapy?
and what are the common indications?
Okay. Allergen immunotherapy in children officially by all recommendations across the globe says 5 years and up. Okay, official recommendation. 5 years and up, you can do immunotherapy. For aeroallergens, I'm talking about now, okay? I'm not talking food allergens right now. Now, the youngest patient that I have done, the indications, obviously allergic rhinitis is one indication. People have used it for allergic rhinitis with allergic asthma also in children. People have used it for atopic dermatitis, which is a kind of a quasi thing. It works, but you can sometimes worsen the atopic dermatitis before it gets better. So you need very good clinical management in place. And then a very big recommendation where I'll share a story with you is venom immunotherapy. It is the most effective immunotherapy that we do of all types. It has a success rate of above 99%. Okay. So I had a child in America who got admitted to our hospital ICU with full-blown anaphylaxis, like in shock, stopped breathing, needed intubation, went on a ventilator. And this unfortunately was that child's second bout of going into the ICU, and she was only 18 months old, 17 something, okay? She had been bitten by what is called fire ants in America. They're a major allergen in America. They occur mostly in southern United States, but they are so resilient, they have now spread along the coast all the way to even Maine and this side all the way to Washington, okay? So the mother of the child was very, very clear that if a child, and you can't avoid red fire ants in America easily, especially if you have a house with a lawn, during summer, they're going to come and make homes there, no matter what you do. And you can't tell a 17 or an 18-month-old to avoid the ant hills. They can't see them. Sometimes they're under the grass. And they're so aggressive that the moment your foot touches them, about 10 to 20 ants will swarm out and bite you before you can move your leg. They're so aggressive, okay? So the mother was very clear that her child could die from this allergy. So she came to us, to our allergy clinic. I used to run an exclusive pediatric allergy clinic in my center, and told me that, Dr. Roy, I can't lose my child. I need to do something about this. So we had already given them EpiPens and all that. And we explained that immunotherapy is not recommended below age 5. She said, my child won't make it to 5 at this rate. The next bite, I may not get to a hospital in time. So after a lot of counseling from a detailed consent, we started immunotherapy in this at the age of 18 and a half or 19 months. We started immunotherapy. Injectable only works. There's no sublingual for venoms. Venoms is all injectable. And it's a high-risk immunotherapy. You can actually get anaphylaxis from the injections. But this kid cried only the first 3 times that she came and took a shot. By the 4th shot, her mom had trained her so well and the child was so understanding of what's going on. We explained, we sat, spoke to her, played with her, told her. She would come and keep her arm and say, give me the shot. She would get a local reaction during the build-up phase. She reached maintenance in 3 months, which is what it takes. And we subsequently continued her immunotherapy. Around month 7 of her immunotherapy, she again got bitten by about 20 red fire ants. And all she had was a typical response that a human being would have, which is local pustules that form at the site of bite. No anaphylaxis, no hives, no angioedema, nothing. Okay. She completed the full 3 years. Actually, 5 years is what is recommended. I was there till the 3-year point. Then she must have continued 2 more years with my colleagues when I left that center. But to answer your question, depending on why we are doing it. So for example, cow's milk protein allergy, if someone has anaphylactic allergy to cow's milk protein, there is an oral desensitization that's considered off-label. There's no protocol to it. There are protocols to it, but it's not recommended as a routine line of treatment. So we have to counsel the parents, tell them what the risks are. So for egg, for peanut, for milk, for tree nuts, we've done oral desensitization protocols, but there's a risk of anaphylaxis with every escalation of dose that we do. So the family has to be really understanding and be clear about it. Like you said, if it is a one that can be managed with avoidance, in most cases, we do the avoidance because we know the child can outgrow it. Then we use something called a milk ladder. We introduce baked milk products and then regular milk products, and they mostly are better by age 3, 4, 5, 7, whatever it might be. But if it is a very serious case, it's hard to avoid due to whatever reasons, child school, work, etc. Then in those situations, we do offer oral desensitization for cow's milk allergy also. But I've had less takers in India. I'll tell you why. Because in the consent, it says in the form that my child could die during this process due to anaphylaxis. And most parents are not willing to sign that form. But I can't do a desensitization without having that signature. So I've had a few who've done it with us, but most are scared to do it because though I may have all the epinephrine and all the oxygen and all the everything, sometimes bad things happen, and they've happened with oral desensitization. The risk of systemic reactions with oral desensitization to foods, especially for nuts, peanut, etc., can go as high as 30%. Systemic reaction. I'm not just talking mouth itching, tongue swelling, lip swelling. I'm talking like full-blown anaphylaxis, hives, urticaria, BP dropping, wheezing, difficulty breathing, etc. happening. Risk is somewhere between 10 to 30%. So you need a consent, and parents are scared to do that, but it can be done. Very much is done. There are many, many studies on this, many publications on this. And as I said, peanut has reached a stage where you can give Palforzia, and where the child, even if they touch peanut, they will have anaphylaxis. Now, accidentally, if 2-3 peanuts go in the body, they don't have a problem because they've taken Palforzia and desensitized. But complete desensitization becomes a challenge. It's hard. And when you're desensitizing, you have to eat the food every single day, not one day you give a gap. And sometimes you have to do that for years together to keep the person desensitized. And they can eventually outgrow it. They can get into complete immune tolerance also. Having said that, now omalizumab has an indication for severe life-threatening food allergies, anaphylactic food allergies to multiple foods, where you can use omalizumab to reduce the risk of getting an anaphylactic reaction, not as a cure for the food allergy, but for a buffer so that when the child goes to school, the parents are not constantly in fear and anxiety कि आज किसके डब्बे से क्या गलती से खा लेगा और problem होगा. So that is there. It's a recent indication come hardly few months ago.
The last thing
Yeah.
for the antigen testing, skin prick testing, do you have any in India, any standardization of the antigens which are used?
There is local standardization that goes on. So every company has their internal standards, and every company follows those standards, whether it is, so India still uses something called protein nitrogen units for measuring the protein content of that allergen. It's one of the oldest systems. Most people have gone into biological activity testing, which is the best way, or histamine units testing, or therapeutic units testing. India doesn't have that. But we have what would be called a semi-standardization of the allergen. So batch to batch, they confirm through their process of testing that this much amount of PNU of protein is there in the antigen that is being supplied to you for skin testing or for immunotherapy.
So from Hyderabad, we have one
Yes,
query.
please. Yes,
Yeah,
please.
sir.
Hello, sir. What is how to treat persistent allergic rhinitis in infancy, sir?
Very good question. We are seeing more and more kids who are 8 months, 9 months, 6 months old and have already developed allergic rhinitis, which is confirmed. So people, as I said, used to say you can't skin test below a certain age, but either you do blood test or above 6 months, I even do skin testing very selectively. If you have a confirmed allergen and you have a confirmed allergic rhinitis, you would use the same antihistamines that you would use in an adult in a pediatric dosage. Some of the dosages may be off-label, okay? But you don't have a choice because that's all you have available. Interestingly, some of the older generation antihistamines have more data or not data, I would say, but more comfort because of people using it for years together. But the newer generation antihistamines, whether it be fexofenadine or be levocetirizine, do work quite well in these kids also, okay? And they have indication ages down to 6 months and up or 1 year and up. Nasal steroids, officially, mometazone furoate has an indication down to 2 years of age. So in these situations, if you needed to, the first option always is allergen avoidance. So if the kid has a dust mite allergy and is sleeping with 4 stuffed animals or stuffed toys in their bed, get rid of the stuffed toys, use the dust mite precautions, use everything else that you can. And then in addition to that, you may use a oral antihistamine and if needed, very selectively, very carefully with close monitoring, a nasal corticosteroid, which would be off-label.
Yes, like how long we can use, sir?
As
Duration.
long as the symptoms are there.
Any role of nasal antihistamines, sir, in infancy?
I have never used
Azilastine.
it. I have never ever used it. And I don't think I didn't need to use it because I'm yet to find a child who had that severe of a persistent allergic rhinitis that I had to give them a nasal antihistamine. Just hasn't happened. And I've been practicing for 25 years. Maybe now that you're saying it, someone will show up. But as of now, between oral antihistamines and nasal steroids, maybe nasal saline sprays, etc., I've been able to manage, and allergen avoidance, I've been able to manage most of these kids.
Sir, if want to use Azilastine 0.1%, like for like how long duration is it? It will be safer.
It's only officially approved for 6 years and up.
Okay, sir. Like
So
0.1% is also like I have heard like 0.1% can be used from 6 months to 2 years.
is
it
there a
so, sir?
preparation? Is there a preparation of 0.1% in India?
Yes, sir, it's available.
As a pediatric Azilastine?
Yes, sir.
Okay. Which company, if I may ask, please can you tell me?
Like 1 minute.
That's okay. You can search and tell me. So if the company has an official indication and says that we are officially letting you use it down to 6 months of age, then you are safe. Otherwise, you're going really into an uncharted territory with these patients. So be careful is all I would say.
Amneal.
Good afternoon. I
Did
am
you
from
say something?
Kolkata.
Amneal.
Amneal.
Yes, sir.
All right. I'll look
Hello.
it up. I'll look
Okay.
it up.
Good afternoon. I am Dr. Basu from Kolkata.
Yes, Dr.
Uh,
Basu, please go ahead.
In my two child of about 16 years old, I am getting the boy is having urticaria and allergy in every 48 hours. I by exclusion, I thought it is a stress associated urticaria or allergy. Only 5 milligram of levocetirizine reduces the symptoms. I am using it for last 2 years. So, but it is continuing. So, can I use it for long more years, or is there any other treatment? That's all.
So you said the patient is 16 years old, correct?
Yes.
Okay.
Two patients like
Two
that.
patients. Okay. All right. So the answer to your first question, for chronic urticaria, there is no upper limit for how long you can use antihistamines. Okay. What you have to realize is in chronic urticaria, especially in a 16-year-old, you have to do a very thorough workup to rule out autoimmune diseases, certain infectious diseases, certain inflammatory conditions. And also, I find modifying diet extremely helpful in getting these people off drugs. I can't go into the details of it right now, but definitely a workup with an ANA, workup with an antithyroid antibody panel, workup with looking for urine, liver function, etc., looking for other causes. So chronic urticaria has many, many, many well-known, well-defined triggers, which if not detected, we will never treat. H. pylori infection is one of them, very common in India. Okay. The next thing that you mentioned that I would tell you is that omalizumab is approved for treatment of chronic urticaria, and we will do this in more detail in the urticaria module. I hope you can attend that.
Anti-leukotriene.
No. Anti-IgE, omalizumab, injections.
Okay.
Okay. So that can sometimes be an option in a 16-year-old if need be, because 12 and up, it is approved down to 2 years of age, as I said, for serious food allergies, multiple food allergies. So technically a 16-year-old falls well within the age group that it could be used. But I would do a workup before I would use omalizumab. I would definitely do a workup because 5 milligram of levocetirizine is not a very high dose. You know, we think of omalizumab when someone is having to take 3-4 doses of levocetirizine 5 milligram through the day, then we think of omalizumab. With 1 dose of levocetirizine taken daily, if the person is well controlled, I
Only
would say,
every 48 hours.
yeah, so that kind of a case, you don't need to do much more. Try to find other causes and keep the antihistamine on.
That I continue for 4 or 5 years.
Like I said, if the patient came to me, my workup would be fairly intense for this person. Are you a pediatrician?
Yes, I am a pediatrician.
Okay, so you would need to look up, as I said, I gave you some of the tests that I would do. You have to look for thyroid, you have to look for antithyroid, you have to look for ANA, you have to look for H. pylori, you have to look for a bunch of things and find these. If these are there, you have to, they are treatable. You can
He
actually
has
get
got
rid of the
duodenal,
disease.
he has got duodenal ulcer also. Yes, H.
Got
pylori
what?
positive. He has got duodenal ulcer also. H. pylori,
Duodenal ulcer also. So is his H. pylori positive?
H. pylori positive.
So it needs to be treated.
Not-
He's probably not, he's resistant. I have patients who've required a endoscopy with biopsy with culture to finally figure out which antibiotic would work for the H. pylori. So you have to really go after that. It's a major trigger for urticaria.
Okay, thank you.
Sir, Bangalore.
Nagpur has a question. Please go ahead.
So Bangalore is having one question, sir.
We'll come to Bangalore after that.
Okay. Sir.
Hello.
Yeah, please go ahead. We can't hear you, doctor. No sound is coming through.
Hello, I'm speaking from Pune.
Okay. Nagpur, can you please fix what is going on? Till then, we'll take the question from Bangalore first, because Bangalore was in line, please. And then we'll take Pune also.
Hello. Hello, sir.
Again, we can't hear Bangalore.
Good afternoon, sir.
Yeah, we can hear you. Yeah, go ahead.
Thank you for the very interesting talk we had.
Thank you. Thank
my
you.
question is, the patient coming with, I have a patient with who is having chronic urticaria as well as allergic rhinitis. So what any management-wise, what is the difference between chronic urticaria and allergic rhinitis?
What's the age of the patient?
Age about 35 years.
Okay.
He's also having asthmatic attacks also.
Right. So this patient definitely needs to see what I would call a specialist, because they have 3 manifestations. 2 may be allergic, 1 may be non-allergic. Chronic urticaria in a 35-year-old may not have anything to do with allergies. Okay. In fact, when you look at allergic triggers for chronic urticaria that is going on for more than 6 weeks, less than 5% chance that an allergy is causing the urticaria. So the allergic rhinitis and the allergic asthma needs to be managed well with proper allergy skin testing, proper nasal corticosteroid, ICS, LABA, whatever is required, bring them under control, do their urticaria workup. If the urticaria workup is not showing anything and you've done a fairly considering of drugs like omalizumab. And as I said, I lay a lot of emphasis on diet. Diet is a very big part of why people keep getting urticaria. I have 3 diet counselors on my team who work with patients, not just in my clinic, but all over India and all over the world. And that has made a huge difference to a lot of my patients coming off medications, because sometimes we are eating foods which are triggering non-allergic reactions in our body, which then cause urticaria. And as I said, we will have a whole module on urticaria. Please attend it. I can't get into more details. I'm already giving you very valuable information here.
So one more question, that does the deworming help in the management of urticaria?
If your patient has that kind of a lifestyle where you think that they'll be getting worms, as you know, worms are not as prevalent amongst the higher socioeconomic classes, people who are not eating from outside a lot. If they're in an age group and in a range where you I see people getting dewormed again and again because they're getting urticaria. That's wrong, in my opinion. You better have a good stool test with ova and parasites or something to confirm if you're going to give multiple courses. If you give one course or one round, nobody can fault you in the country of India yet. I don't even do that. I like to get a proof or some history, anal pruritus, passing worms, some other thing, abdominal pain that can't be explained by anything else, a positive stool test, and then I treat. But one round of deworming, I don't think anyone can fault you for that. Repeated deworming without proof would not be a good idea. And I see people use diethyl carbamazine all the time and, giving 21-day courses just because their eosinophils are a little elevated. Again, something that most of the time it's allergies causing it. And if you treat their allergies, they get better. But there are certain patterns of practice that have been going on for a very long time. We have to update and upgrade ourselves about when and how to use them.
Okay, thank you, sir. Thank you.
Welcome.
Hello. Hello.
Yeah, Nagpur is back. Please go ahead.
Sir, Dr. Akash Chakoli here.
Yes.
Sir, as you said, there are many subclinical asthma cases. How to identify subclinical asthma cases in pediatric patient having allergic rhinitis and how to manage it?
Okay. Very relevant and important question. We have our next module, which is going to be asthma, allergic and non-allergic. Please attend it. I'll give you a brief answer. Below the age of 5, there is a test called forced oscillometry test, which can be done to diagnose asthma. Above the age of 5, most kids can do a pulmonary function test or a spirometry. If neither can be done, then it's a clinical diagnosis where you ask about the child's sleep, about the child's exercise capacity, about the child's recovery from a viral infection. Many things can give you an indication that this child is becoming asthmatic. Response to bronchodilators, response to oral steroids with bronchodilators. There are many things, but a clinical diagnosis is through forced oscillometry testing and through spirometry. An exhaled nitric oxide or a fractional exhaled nitric oxide test can also be very beneficial in these people.
And sir, how to manage below 5 years?
Manage asthma?
Yes, sir.
Next module.
Okay, thank you, sir.
सब कुछ आज पूछ लोगे तो एलर्जिक राइनाइटिस और राइनोसाइनोसाइटिस रह जाएगा. बुरा मत मानो, बट मैंने डिजाइन ऐसे किया है. Come to the next module, please. Thane, please.
Montelukast with levocetirizine combination or montelukast with fexofenadine combination in the treatment of allergic rhinitis. When do you start? How long do you give in cases with recurrent exacerbations of allergic rhinitis? Maybe around 2 years child, maybe 3 years. I'm a pediatrician from Thane, sir.
Yes. Very good question, very relevant question. So, as you know, levocetirizine again has an age indication down to 6 months. Montelukast also has down to 6 months, if I'm not mistaken. So, in a 2-3-year-old, you can definitely use it if you have enough indication. You have done a total IG, you've done some allergy skin testing, you're convinced that it is largely allergic. I would prefer, if you're going to give it for a prolonged period of time, that you have a solid diagnosis. That's very important. Whether you do that through skin testing or through blood testing is your choice. Once you have a diagnosis, frankly, there is no upper limit to how long you can use it for. Okay?
Okay.
The studies that have been done for montelukast for allergic asthma, or that have been done for levocetirizine for allergic rhinitis or any of these other indications, are 52-week studies. They are 1-year studies. Otherwise, US FDA does not give them approval for a chronic disease. So I know in India, there are a lot of pediatricians who will only give it for 1 to 3 months and then say, stop it and let's see. When you do that 2-3 times, that's when they find me on the internet and come to me.
Sir,
because they're not doing well when you're stopping the drug.
Yeah,
Okay?
the patients
So-
do well in summer season if you stop them from giving it. I mean, if you have given it regularly for 6 months, it works well. And thereafter, if you stop, they do well. But then over a period of time, maybe another 3 months later, they again require the drug. So, montelukast levocetirizine or montelukast fexofenadine, any preferred combination?
My preferred combination is with fexofenadine because I don't want even the 10% chance of drowsiness that levocetirizine has in children, which may not show up as a clinical issue, but can potentially sometimes impact their cognition or learning or those things. Not that I don't use it, I use both preparations. There is a little bit of parental preference also there. There are parents who believe that the levocetirizine montelukast works better than the fexofenadine montelukast. So I'm open to both, but as the kid gets older and starts going to school, I prefer using fexofenadine versus levocetrizine.
So
My
any upper
personal
limit
choice.
for giving? Upper limit, I mean, how long can you give? You can give it even for a year together?
I have, and there's no data that says you can't use. Like I said, if I'm having to keep someone on an antihistamine or an antihistamine Montelukast combination for a prolonged period of time, I've made sure that I've done as much allergy testing as I need to. I've made sure that I've had a very clear discussion with the parents about allergen desensitization so that I can, by immunotherapy, change that child's natural history and course of disease. And I have started off-label sublingual immunotherapy even in 3.5 and 4-year-old children for desensitization. The answer to your question is, if you can get away with a nasal steroid, okay, and you
Yes,
don't
sir.
have to use an antihistamine, do it. If you can get away with a nasal steroid and don't
So
use,
nasal steroid, how long can you give? 3 months?
again, no upper limit till your patient needs it. The
Okay.
answer, because these are chronic diseases, this is well recognized. There is this entire, what I would call fear. I don't know why, because that's how you all have been trained probably by your professors and seniors, that don't give this for long, stop it after 1 month or 3
Sir,
months.
it is not the fear from the teachers, it is fear from the patients. They keep having, rumors all around steroids, this, that. So it will not work, it will have addiction. So many rumors are
Counseling,
there. Even if we say
counseling.
counseling,
Agreed.
understood. Sir,
Agreed.
dosage, nasal steroid dosage BD
No,
or
no,
OD?
Q-day below 6 years of age. Below
Okay.
6 years of age, only once a day.
Only once a day.
Like if you have a severe exacerbation, you could use a BD for a limited period of time,
Yeah,
maybe a
agreed.
week or 10 days or whatever. Your biggest risk there is nosebleeds in young children. Okay.
Okay.
So you
And
may
sir,
need to
preferred
use.
timings, morning, evening, if OD? Any day, any time of the day?
Not really. It's a 24-hour drug, right? So you get it into the system every day. That's what you do.
Okay.
That's your goal.
So what's the role of flu vaccine in allergic rhinosinusitis? Any role?
I use it a lot because influenza is something that takes them from having allergic rhinitis to eventually getting their first wheezing or asthma attack or whatever else. So it doesn't have a direct indication. But as you know, in America, the indication for flu vaccine is you just have to be 6 months old and up. You don't need
Sir,
to have any disease or any problem.
It does work for the patients with allergic rhinitis.
I
That is
told you,
what
I
in my
use it.
clinical observation.
Yeah, I told you, I use it all the time. I
Yeah.
offer it to every single of my patient who has
Thank you,
allergy
sir.
because
Thank you, thank
their respiratory mucosa is not healthy and they very easily get infections. And if they're a school-going kid, they're going to get flu twice a year, once in monsoon, once in winter. If I can avoid it, praise the Lord. Let's do it.
Thank you, sir. Thank you.
One question locally in Mumbai, I have one or more than one. We have two questions here. Please go ahead.
Hello, I'm from Pune.
Pune was before. Let's wait. Pune was on waiting. Please go ahead.
Any role of belastin? And second question is, what is the cost of immunotherapy?
Okay. Belastin age group officially, okay, that you can use it for officially at the dosage of 20 milligrams or 40 milligrams is 12 and up. There are preparations that have been made in India in the syrup form of 10 milligrams, which they recommend down to 6 years of age, as far as I remember. Below 6, it would be an off-label use that you would be using, okay? There's no harm in using it. I don't see any reason why you couldn't. But officially, most parts of the world, it has been used in 6 and up. I think it's relatively the least of the studied antihistamines in some ways, only because it came later on the market and people were fairly complacent and confident that it is good, it's non-sedating, everything like that. I try to stay within guidelines, so I don't use a lot of belastin below 5-6 years of age. I prefer to go with drugs that I have long track record with. That's just my nature. Okay. The principle that we all doctors follow is do no harm, don't experiment. I do experiment a lot in other ways, but where I can, I'll stick to what works. So levocetrizine, fexofenadine works, so I tend to stick with those. But belastin can be used. It's your personal preference. Monitor, observe carefully, use it where you need to. You had one more question, or was that it?
What is the cost of immunotherapy?
Cost of immunotherapy. Okay. So let's see, if you're doing with Indian allergens and Indian antigens, subcutaneous immunotherapy can be not very expensive, fairly inexpensive. There are lots of problems with the protocols that are followed. That's a different story. But probably somewhere around couple of thousand rupees per month is what most people charge, even for sublingual and subcutaneous. It may be even less because you can get antigens ordered with mixing from the company at a not a very high cost. As I said, couple of thousand for a couple of months of therapy when you order them. But the key is that when you're doing subcutaneous, you have to rely on the company to be doing what they're saying they're doing, which mostly they do, but you don't have any control on the quality of the allergens, the quantity. The transportation is a big issue in India. Immunotherapy, subcutaneous or sublingual, has to be transported in cold chain. By the time most of my medicines come to me, they're warm in India, especially in summer. I have to pray to God and still use it. I don't have a choice. But the new tablet that has come out for house dust mite, and it is going to be only through allergists that it will be given initially, because there's a high risk of local reactions, up to 30% risk of local reactions with tongue swelling, mouth swelling, gum swelling, lip swelling, itching, etc. But that is going to cost around 9,000 per month.
Okay.
So the Indian allergens are much cheaper compared to that. Obviously, that is a standardized product released in 45 countries, and we are using something that we have used here.
Fine, thank you.
All right.
Yeah.
We have, please go ahead. We have local questions, just a second.
A very nice and elaborative lecture.
Thank you.
Yeah. So I had a question that doing immunocap IgE, does it have added advantage than doing plain IgE test?
Plain as in total IgE.
Yeah. Total
Okay.
IgE and immunocap IgE.
Total IgE helps you. So immunocap is only a system of testing. Okay. When you do total IgE, it is done by a standardized process that different machines have different. When you're talking immunocap, you're talking of specific IgE. So I'm going to answer you as total IgE and specific IgE. Okay. Doesn't have to be immunocap. There are other systems also. So total IgE is helpful when it is elevated. You have a suspicion of allergy and the level comes high, you know you're in the right direction. Problem is when it comes normal, people think allergy nahi hai. That's a problem. I have anaphylactic patients whose IgE level is 25 or 40 or 60, which is normal, and they have anaphylaxis. Okay. And I have patients whose IgE level is 12,000 and they have no allergies. So total IgE has lower what we call sensitivity and specificity. But when in the right clinical picture you do it and it's elevated, it's a very good reinforcer to that you're on the right track. Now, specific IgE is something that you do when you have targets that you're going after. So labs ने panels बना दिए हैं. मैं panels कभी नहीं लिखता हूँ generally. Selective cases में लिखता हूँ. But if I'm doing specific IgE, then I'm doing it to, let's say I have a patient with cow's milk allergy. So I will order a specific IgE to cow's milk. There's now CRD also, BOSD1, BOSD4, BOSD5, which are the subproteins of milk to know who will have chronic allergies that they won't outgrow and who have allergies that they could outgrow. Again, we'll come to the food allergy module for that eventually. Point being that specific IgE, you need to know your targets. Otherwise, you're going to do a generic test, then you're going to get a generic report, then you're sitting and correlating with the patient, is this relevant or not? Especially if they have a high total IgE. You get a lot of false positives on specific IgE. So use it cautiously. There are a lot of allergists who don't do total IgE. I do. I find it very beneficial, very helpful. I know how to use it. That's the key. So if you know how to interpret the total IgE, which means even if it comes normal, you should be able to tell your patient normal doesn't mean you don't have allergies. We have to investigate further. Skin testing, blood testing, specific IgE, CRD, whatever it might be, if your suspicion is high. We even go to the extent of doing provocative challenges when we have a high suspicion, because 15%, I didn't go over this in today's lecture, but 15% of people with allergic rhinitis have only a local allergic rhinitis. Their skin test is also negative, blood test is also negative. But when you instill the allergen in their nose, they have full-blown allergy symptoms. Okay. So stepwise, IG is just a screening test. If it's high, helpful. If it's low, not helpful, proceed with your next level. Answers your question? Perfect.
But sir, if you
Yes,
are
one second,
getting
one
hyper IG like that 1200 and something like that,
Where
you
is this
do,
coming from?
yeah,
Okay, all
you
right.
think of getting a hyper IG like a 1200 and something like that. Do you think something like that there can adapt to hyper IG syndrome or
Okay.
something like
So
that?
job syndrome or hyper IG syndrome, I don't think of in a 1200 or a 2000. Okay. For me, job syndrome has IG levels that are really high. We are talking like 10,000 and up. You can get it in kids, even in younger groups with lower IgE. But all the classic hyper IgE syndromes that I have seen in my career, none of them have had IgE levels below 5 or 10,000. Okay. Having said that, can it occur? Yes, it can. For me, hyper IgE syndrome is like a spectrum. It's like autism. At one end, you have highly functional people, but they're autistic. At the other end, you have people who are, so same with hyper IgE. They have a high IgE, but very little problems. At the other end, they have bronchiectasis, they have recurrent infections, they have abscesses, they have dropping lung functions, they are miserable, they have a lot of problems. So I think hyper IgE is a very selective topic and a selective discussion, but in a 1200 or 2000, I may think of, I didn't get into allergic fungal sinusitis again, or allergic bronchopulmonary aspergillosis, which I will get into in my next module. But when I'm getting 1200, 1500, 2000, and they're having allergic kind of issues, I'm thinking more of AFS or ABPA than hyper IgE. I hope that answers your question. Yes, ma'am.
Good afternoon, sir.
Good afternoon.
Sir, as a continuation of previous question, above what level is total IG considered significant or positive?
This
in
is a
clinically
loaded
relevant
This is
situations?
a loaded question. I'll tell you why. Most of the labs and the machines that they're using are all imported machines, and they come with criteria or parameters, right? So you'll see sometimes the lab reporting that anything above 150 is an allergy, anything above 120 is an allergy. Then you'll see one lab that will say anything above 398 is an allergy. This is all arbitrary to me. Okay. What do I mean by arbitrary? In India, when studies were done, especially in children and also in adults, it was found that the baseline IgE level of Indians is higher than the rest of the world. Okay. So where 150 may be high in America, a 200 may not be high in the right clinical picture. Hence, I said total IgE is only a screening test, nothing more than that. When you're giving omalizumab, it gives you an idea. You're doing other types of biologics, it's relevant to know what the level is, how it will work, the drug. But when it comes to diagnosing allergies, I use a criteria to go with what the lab is telling me is their cutoff for that patient. And so I think you need to take that with a pinch of salt. But the cutoff, go with what the lab says and then go with what the data says. So there are some pediatricians I know who have done research on this, who actually say that even a 250 in a child may not be, or in a teenager may not be that high. But I don't take that. मेरे लिए nothing in life is a one size fits all. ये मैं सीख गया हूँ after spending 35 years in the field of medicine from the day I entered med school. One thing if I have learned, patient book पढ़ के नहीं आता है, guidelines सिर्फ guidelines है, cut off सिर्फ cut off है. हर एक person rule तोड़ने के लिए पैदा हुआ है. I hope that helps you.
Sir,
Good afternoon,
and
sir.
in allergic rhinitis patients, is Montelukast alone preferred than the combinations?
Never use it. Never, ever. There may be others who disagree with me, but I never, ever use Montelukast alone. It's a very weak drug for me. Does it work? It works. Please don't get me wrong. But if I'm using Montelukast alone, I need to have something with it that I'm doing either for the person's asthma or allergic rhinitis. Montelukast alone will work in your very mildest of patients, and understand I'm a super specialist. मेरे पास mild cases नहीं आते हैं. So my experience with using Montelukast alone is.
And sir, if an allergic rhinitis patient who is already on intranasal steroids come to our OPD and PFT has not been done before, so is there any period we need to get the steroids, intranasal steroids off before
Not
doing
at all.
PFT?
Not at all. You can test the very same day. Totally okay.
Okay. And sir, the youngest age you had mentioned about doing skin prick testing was about 6 months. So generally, what is the minimum age we should refer a patient or we should get the skin prick test done?
This depends on two things. It depends on the comfort level of the allergist who is testing. So some allergists are not comfortable testing very young kids. I recently found out a very big institution in Mumbai does not do allergy skin testing below 5 years of age. I was surprised and I told them my experience and I told them why they could. But it really depends on where you're sending and whom you're sending to. So if you send to me and the history is strong enough, I'll test at any age. And if I can't do a skin test, I'll do a blood test, right? So it depends on the person you're referring to for testing and your history, the strength of your history. Otherwise, there's no limit to that thing because you need a diagnostic test. You can't just अंधेरे में तीर नहीं छोड़ सकते कि ये शायद डस्ट माइट है, ये शायद ये है, ये शायद ये फूड है. You need a specific diagnosis.
Okay, sir. Thank you.
From
Good
Surat, we
good
have a
afternoon, sir.
question. Yes, good afternoon.
Yeah, good afternoon, sir. My patient having allergic rhinitis since 8-9 years, most probably due to dust or pollen. He's taking Allegra regularly. How you proceed for that? Since 8-9 years, he's
Age
having
of the
allergic
patient,
rhinitis.
please.
Sometimes
Age of the
30
patient,
years.
please.
30 years.
So the first thing that needs to happen for a patient who's been taking Allegra for 8-9 years is they have to be allergy tested. If they are being treated without being allergy tested, that's a major breakdown in the protocol that we follow for treating allergies. So the first thing is get allergy testing done. Once you get the allergy testing done, find out what their real triggers are, guide them. So don't just assume ये शायद dust है, ये शायद pollen है, ये शायद mold है, ये शायद pets है. ऐसे नहीं होता है. आज के डेट में in 2025 in a country like India where there is widespread blood allergy testing available, which is not my first priority, and skin testing available, you need to identify good allergists in your area.
At present, he is studying in US since 7 years.
When he comes back for a vacation, test him. There are very good allergists in America. There are 4,500 allergists. I was one of them when I was to live there. So allergy testing can be done wherever you want in the world. It's not difficult at all. When they come back to India, tell them to be off Allegra for 3 days and test them.
He is not taking regularly Allegra, sometimes off and on.
Even if it is off and on, 8-9 years is a long period of time to take a drug. कौन दवाई ऐसे ही लेते रहते 8-9 साल तक without a proper diagnosis and treatment? Means आज के डेट में you can desensitize this guy and he can be free of his Allegra. मेरे लिए वो सही नहीं है, दूसरों के लिए हो सकता है. मेरे लिए as an allergist वो सही नहीं है. We need to get to the root of it. Allegra is symptomatic care. You need. I am a hardcore believer in root cause therapy. रूट कॉज थेरेपी के काम किया तो वो पर्सन तो आपको जिंदगी भर दुआ देगा कि डॉक्टर साहब ने हमको सही इलाज दिया, सही डायरेक्शन दिया. वेलकम. Thane, we have a question.
Good afternoon, sir.
Good
My name is Dr. Vinod. Sir, thanks for giving the enlightening the hot topics, which is burning, which are we are going to interact in day-to-day life or day-to-day OPD. And I have two questions. One is for this key. One is celiac disease or gluten intolerance, these things. How we see the immunotherapy in this case? And second question is this, we have the three modalities like medications, preventive aspects and the immunotherapy. Other than these things, any modalities which is upcoming or any RCT is going to be conducted in future or any updating things are going to be happen in future, so we can rely on that further.
Again, you've asked me three questions. Let's go with one at a time. What was the first question?
Yes. What do we see? How we see the celiac disease or gluten intolerance test?
Gluten sensitivity is a IgG mediated disease, IgA mediated disease. Immunotherapy has absolutely no role, in my opinion, in this disease. Shouldn't be tried, shouldn't be experimented. I know certain parts of the world people are swearing that it is working. I have not seen concrete and good data to suggest it to anyone at this point of time. So
are
don't
there
try
any
it.
option for this?
For celiac disease? Avoid gluten and gluten containing
That's it.
foods. It works fabulously. I have patients I'm treating. They are living
Yeah.
a fabulous life, so superb health. They're just avoiding that group of foods as of now. Later on, there may be something, but I don't have a strong clinical research, randomized, placebo-controlled trial data yet to give immunotherapy to anyone to celiac disease because it's not IgE mediated. It is IgG and IgA mediated.
Right.
And there is no, means food desensitization is a very tricky topic. People who are claiming that it works, I have questions about it. Really, I do. Second question.
Second question, as we know, there are three modalities we have. One is immunotherapy, medications, and the preventive aspect. Are there any upcoming modalities which is coming, which can solve these our hurdles? Because allergen is just too much big issue in our.
The
this
holy
thing,
grail for the future is modulating the gut microbiota.
Yeah,
We are
which is upcoming.
we are light years away from, maybe not light years, we are years away from getting the right answers. We still don't know enough. There are too many bugs in there. They change with time, they change with diet, they change with lifestyle, they change with genetics. We still don't know who all the perfect good guys are, who all the perfect bad guys are, what combination of which bugs you need, because Mother Nature is very, very smart. It doesn't work with one bug. So if someone tells you कि ये दे दो आपका बच्चे का एलर्जी ठीक हो जाएगा, वो सच नहीं है. Not that I don't use probiotics in my practice, I do use them, but that's going to be the future. I believe that westernization of our diet and lifestyle, which was a big part of my first presentation, is a huge issue. We need to go back to our roots of eating naturally in the Indian style, Indian foods,
Right.
not the packaged, not the processed, not the kind of stuff we are feeding our kids and eating ourselves, like the juice being served to you right now behind you is a processed juice, okay? You would be much better eating the fruit. But what are we doing? We're going to step out of here and we're going to eat processed food in a few minutes.
But
So
microbiota,
please,
which has we having the studies, which has having the not means established the form of this data. So we cannot go conquer that key. It means sufficient to give the correct answer.
But the answer to what you're telling me is going to lie in the mother's life and the mother's womb. I
Right.
strongly believe that in ancient India, we had a process called Garbh Sanskar,
Right.
in which
That is
mothers
more.
were kept happy, mothers were kept healthy, mothers were fed beautifully, and they were treated like they were queens, is the only word.
That
The
Garbha
day we
Sanskar
start-
is
The
important.
day we start doing that, I think we'll be producing less allergic babies. Now,
we need
that is not a simple thing as just what I've told you. It's a very deep process. And from there, the mother's diet, the mother's lifestyle, the mother's stressors, then the baby's birth, the baby's diet, the baby's lifestyle, the baby's stressors. When we work on all of those things, we'll go back to bringing India in the bottom 20 of the least allergic countries in the world. The biggest thing, again, I'm telling you, air pollution and food pollution. If you and I, as doctors, don't raise our voice against this, we are doing a huge disservice to our next generations.
Because if you see the prevalence right now is going to very high as compared to the 50s decades or back to go. As we see the
You
lifestyle
forget
and
50s. I'm saying in the 90s, India was in the bottom 20 countries of allergy prevalence. 90s, bottom 20 countries. Okay? Today
What
we
is
are
our-
in the top 20.
what
We
is
are
our
skyrocketing.
traditionally what we see in the back eras that ki mother how is means in the antenatal period how is taking care. Currently we are not taking care that much way. So such a thing is going to be higher prevalence. I
See,
think.
I'm a so strong believer in all this. I'll tell you that even from the stories that we hear from Mahabharata, that how Abhimanyu in the Chakravyuh could get trapped because he had heard it in his mother's womb from what Lord Krishna was telling him. Imagine what mothers today are doing, sitting with their mobile through pregnancy, looking at stressful movies, looking at anxiety-provoking movies and web series. I think the programming begins from there. I don't know how else to tell them, but I know some of the women in the room may not like me saying this, but you know what? Programming begins from there. It's first mind programming and then body programming. Genetics comes afterwards. Our genetics are very good. We have survived. We had Rishi Munis living to 200 years just like that. एकदम हंसते खेलते. हम लोग उनके वंशज है और आज 50-60 तक पहुंचने को लोग तरस रहे हैं. ऐसे ही नहीं हुआ है. जरा पाश्चात्य संस्कृति को छोड़ो. जरा भारत देश में वापस आओ. There is lot to learn from this place.
Thank you so much, Paul.
Yeah, hi. I'm
Yes,
Dr.
hi.
Modi.
Yeah.
Interacted
Good
with you
afternoon,
last
sir.
time. I'm
Good
a
afternoon.
Very
physician.
nice lecture.
Just hold on one second. We have a local question. I'll come back to Thane in just a minute.
I just want to ask, you said that relation between the AR and the anxiety depression. So how they are related? Is there a direct pathophysiology or is it just a coincidence?
There's a direct pathophysiology. So when you get AR and AR gets bad, you actually release cytokines in your body, which make you feel like you're constantly sick. So IL-1, IL-6, TNF alpha, these are high pro-inflammatory cytokines. When you have those constantly circulating in your body, you can be fatigued, you can be tired, you can be scared, you can be afraid. And then when I talk about the neuroafferent pathways that are there, in those pathways also, when your nose is blocked, you're not breathing properly, you're not sleeping properly, you're not getting restful sleep. Imagine if someone kept your nose half open all night, every single day for every single day of your life. Are you going to be in good health? Are you going to be peaceful? Are you going to be calm? No, you're going to be irritable, anxious. And when you take that, depression just doesn't come only with the disease. There are other things going on with the person's life that are causing stressors. So there are very good mechanistic pathways that have been worked out for this, both neurologically, high cortisol release, cortisol affecting the HPA axis, causing a lot of cytokine changes in the body that these allergies do, the allergens do when they release it. There are chemokines, cytokines, there's tons of pathways. I would suggest you to read the textbook chapter that I wrote on stress and allergic diseases. You will see how deeply this is root connected with so many influences, means our hormones get disturbed, our nervous system gets disturbed, our gut gets disturbed, essentially our life gets disturbed. This is in severe cases, it doesn't happen in mild. In mild, it can be a contributing factor, it won't be the primary factor. But it is very much proven pathways and connections by which these things happen.
Thank you, sir.
We have a question from Thane. Please go ahead.
Yeah, hi, Dr. Roy. I had interacted with you last time. I'm Dr. Modi. I'm basically an internist, if you talk it from US angle, and I'm board certified in artificial intelligence. There have been some very interesting updates on AI in allergy. I don't know how it is practical in real life. Any experience over there?
So the only, do you have a specific portion of AI
No,
that
I'm
you
not.
feel
I'm
is
not talking of Gen AI as such. That is
okay?
something we all use. Have there
Okay.
been any FDA approved algorithms or something which have been used? Because I was reading few reports where some things were done better than managing the patient. I'm not talking of chatbots to give the help. I'm talking more of algorithms identifying diseases. I mean, there have been some recent news about the trials and all that have been conducted have been found to be falsely analyzed because of AI. The cardiac studies have been getting revisited now. So the pathogenic pathways are changing, the approach to
Got it.
therapy, because AI is discovering some fantastic new modalities of therapy, especially in diabetes. So has there
Absolutely.
been any updates over there?
Absolutely. So there's a good amount of work going on both in US and Europe, looking at how to optimize. One of the things that required in allergic diseases, chronic allergic diseases, is patient tracking. Okay, when you get patient tracking, right from having uh, things installed in their nasal sprays or inhalers, which tell us how often they are using it, to the medications that they're taking from refill history, to what their symptoms are on a day-to-day basis by having a simple feedback process, it's been possible to optimize their treatment immensely. Okay. Also, with regards to drug development, we are getting a lot more new drug targets that AI is suggesting to us, which will become really groundbreaking in the near future. So I think that in more than one way, right from diagnosing allergies to tracking allergies to treating allergies to eventually optimizing, what I would call customizing the treatment to what the patient needs, AI is being studied in all of those aspects right now. And right now, the maximum work that has been done has been with data collection and analysis in very large trials and studies of these patients who are on treatments and trying to optimize their, because previously it was questionnaires and those things that you did. So there are ways to do that through AI, which is very, very successful. And also getting cross-country data, analyzing large sets of data which exist in Europe.
That will be through NLP. That is where NLP
Yeah.
is playing a role.
Yeah.
And can I take a moment here? I'll take your
Sure.
contact number from the Pharma Associates. But
Sure.
then we are running this global summit on AI, which we did in December. I'm one of the founders of Doctors AI and Doc Yantra. I'm one of the founders. So
Okay.
we are running these MedSynapse International. Dr. Harvey and Anthony, who's the father of AI, they connect with us many times to give international talks on that. So would you be comfortable if I invite you as a faculty in one of these talks? Maybe you can, but that will be purely limited to AI and its role in allergy, and not pure allergy. It has to
talk
be
about it.
absolutely focused on AI only.
Yeah,
Because
got
we
it.
are promoters of AI and we want AI to
Got it.
get the
Let's,
idea. So
yeah. Let's talk about this. I think the hetero team can
I'll
give
get
you
in
the
touch
number
with
and
you.
we'll get in touch. Yeah, okay.
Thanks.
All right, I think we're done with all the questions. Thank you very much for being a great audience, and look forward to seeing you all in the next module if it interests you all. I hope you all do. But thank you. Can we just go back to the last slide of the screen and present that here, please? So the module ka last slide, which is still on in my presentation.
Hello.
Good afternoon. Before closing, thank you, Dr. Sitesh Roy, sir. I think we have all our queries and on this topic particularly. I'll request all of you to please connect with us, our team, for the next module. As you see, there are more modules to come, and we will come back to you with the date and time. I'll request Dr. Khandil Prakash sir to felicitate Dr. Sitesh Roy there. Yes, we will have a group photo after this. Please allow us some time. Yes. Dr. Khandil Prakash sir, please come. Thank you. Yes.
I have been a consultant advisor speaker for every pharma company that you can think of in America. I've done a lot of work with the pharma companies in India, but the vision that they have, if you look at their allergy portfolio, it's not that large. Okay? It's got like 5 drugs in it. But the dedication that they have and the vision that they have for this field in India, it's phenomenal. So a big round of applause for them.
Thank you. Thank you.
Very good location in Mumbai, and we had about 40 doctors who attended that program. Truly, it's visionary what they are doing, and they care about the doctors. That's why they say they have the We Care program.
We care for you.
It's been fun associated. I did lectures for thousands of doctors during COVID with them. We did a lot of online modules at that time and a lot of updated COVID work with them. That's why my association began with them. And this was now 4.5 years, 4 years ago, 5 years ago almost. So, thank you.
Thank you, sir. Thank you. Coming from you, it makes very good difference for us. Thank you. Thank you, all of you. Lunch is ready. You can we can have a group photo if you all don't mind. Just come on the front.